right? So this is all about the renal masses. Now, just as an extension of the point that fat, look at this lesion. So this is a young 20-year-old female who's come to you with distended abdomen, pain abdomen, and this is the CT. So we're down at the level of the pelvis. You can see that from the SI joints. You can see the sacroiliac joint. So we're down in the pelvis. And can you appreciate there is a mass lesion which has what? Which has fat. You also recognize white of calcium. When you see a mass lesion in the pelvis with multiple germ cell derivatives, fat hai, calcium hai, soft tissue hai, what is it? This is what is a dermoid cyst. A dermoid cyst, also referred to as a mature teratoma. So in a female, young female, the most common germ cell tumor that you have is a mature teratoma or a dermoid cyst, and this is the radiological hallmark where you see fat and calcium within it, right? Now we move on to very important, a discussion of the next investigation that a lot of students confuse, that is MCU. MCU stands for micturating cystourethropy. Micturating cystourethropy. So now understand what we are doing. You put a Foley's catheter in a patient and then you are going to inject around 300 to 400 ml of contrast, iodinated contrast, which we dilute with saline. Once you inject 300 to 400 ml, now the patient is going to say that I'm having this sensation of fullness and I want to void. So now you ask the patient, you remove the Foley's and you ask the patient to void. When the patient is voiding or micturating, that is when I take an X-ray. So when you take an X-ray while the patient micturates or voids, you're going to see something like this. So micturating, cysto meaning bladder, urethra meaning urethra. So this is where we filled the bladder with contrast. So the bladder is distended, patient is micturating, so the urethra gets visualized as filled with contrast. Did you understand this? So that is the procedure of MCU. Just to highlight the anatomy, you can see this is the urinary bladder. This part here is what is called as the posterior urethra. It consists of the prostatic urethra within the prostate and a very small part of membranous urethra. So prostatic, membranous make up the posterior urethra. Then this most distensible part that you see here, this is what is the bulbar urethra. Okay, so this part here is what we refer to as the bulbar urethra, and this within the penile shaft is the penile urethra. So together, bulbar and penile make up the anterior urethra. So this is the anterior, whereas membranous prostatic make up the posterior urethra. That's the urethral anatomy there. Now, MCU is going to be very useful. It's the investigation of choice for two conditions. Look at the first patient here. This is a young child who's come to you with recurrent UTI. So when you have recurrent UTI in a child, what is the diagnosis? The most common cause of recurrent UTI in children, and this is reflux, vesico-ureteric reflux. What does it mean? Look at the MCU. We were supposed to see the urethra when the child micturates, but what do you see instead? You see instead that the contrast is going back into the kidneys, meaning this is where the contrast is refluxing back into the ureters. So this is vesico-ureteric reflux. There are 5 grades to VUR. So grade 1 is when you only are gonna see the ureter. So if you only see the ureter, this is what we call as grade 1 VUR. Grade 2 VUR is when you see non-dilated ureter and the kidney. 3 is where you see mild dilatation. So that is when now you are going to see mild dilatation of the ureter and the kidney. 4 and 5 is where you have severe dilatation. What is the difference? In 5, you are going to have this ballooning. Okay, so this is where the difference comes. Look at number 4. In number 4, there is a lot of dilatation, but the papillae impressions are maintained. So this is where the papillary impressions are maintained. In 5, those papillary impressions are lost, and you can see this outward bulge now. That is what is called as ballooning. Here it is still inward. So that's the difference between 4 and 5. They'll not ask you so much depth, but at least 5 you should be able to recognize. Can you see this gross ballooning outwards? So this is grade 5 VUR right here. So this is what we need to know, that for VUR, what is the investigation of choice? It is MCU. Another condition where MCU is the investigation of choice. Now this is where a child comes to you with dribbling of urine. This is the most common cause of congenital urinary obstruction. So this may present in utero as well in very, very severe cases, but most of the time it's going to present after birth as this dribbling of urine or a poor urinary stream. So what is the cause? What is the diagnosis? You did the MCU, you can see this is the bladder, and now the posterior urethra you can see is dilated, and then the anterior urethra is almost not visualized. So this means there is some obstruction here. So what is that? That is a posterior urethral valve. There is a valve-like membrane at the level of prostatic urethra, usually at the level of verumontanum, which does not allow the urine to pass, resulting in urinary obstruction. So for PUV, again, what is the investigation of choice? It is MCU, which will detect the valve here. Alright, what you need to remember, in severe cases, it can also be detected on an antenatal ultrasound. So this is an antenatal ultrasound of a baby with a PUV. You can see this is the urinary bladder and this is the posterior urethra that is dilated, giving rise to this appearance that has been called as the keyhole sign. So this looks like a keyhole and represents the obstruction. What will you see associated with this? Oligohydramnios or polyhydramnios. So because the urine cannot go, we know urine, fetal urine is the main constituent of amniotic fluid. You will have oligohydramnios, and do you remember the sequelae? That can result in Potter sequence, where severe oligohydramnios leads to pulmonary hypoplasia, which may result in death. You have abnormal facies called as Potter facies. So here you have to remember MCU, investigation of choice for 2 conditions, VUR and PUV. 3-letter words, all 4 of them. Okay, so this is about MCU. With that, we go on to urethral trauma now. In urethral trauma, the investigation that we are going to study is this one. So first we'll study the investigation and then I'll teach you the approach to urethral trauma. So this is what we call as RGU. What does RGU stand for? RGU stands for retrograde urethroplasty. So this is where you're going to inject contrast from the meatus. This is where we don't put any Foley's catheter. You're just going to directly inject contrast from the external urethral meatus, and this is going to go enter the urethra and the bladder. So you can see this horizontal part here. What must be this? So now you know the anatomy, so you guys will speak with me. This must be the penile urethra. Where it takes a turn here, what must be this? This must be the bulbar urethra. Yeah, so this is how you recognize the bulbar urethra. And then this thin part. Now, why does this appear thin? Is there a stricture? No, because I'm putting the contrast from the other hand, this is how the posterior urethra will appear normally. It appears narrow normally here because we are going retrograde, right? So this is the normal thin posterior urethra that you see, and this is the bladder. So on an RGU, my main aim is to see, is there a continuous stream of urine or not? If there is a continuous stream of urethral opacification or contrast, it means that there is normal RGU. So this is how a normal retrograde urethroplasty ultrasonography will appear. With this in mind, now let's jump to the approach to a patient with suspected urethral trauma. First of all, when will you suspect? What will be the history? Here, the patient will give you two buzzwords. First buzzword is inability to void. The patient will not be able to void urine. And secondly, we will see that there is blood at meatus. So this is very, very important, that inability to void urine with blood at meatus is the hallmark of urethral trauma. You need to remember the risk factors. For anterior urethral trauma, you may have straddle injury. Straddle injury means patient is walking, has a fall, perineum first. So that's straddling of the perineum leading to anterior urethral rupture, whereas pelvic fracture is what is a risk factor for posterior. So you can remember P for P. So this is the clinical background of a patient with urethral trauma. So now what will be the next step? The next step that you have to ensure, before even I go to the next step, what is it that you will not do? When you have a patient who is suspected to have urethral trauma, remember what is contraindicated is Foley's. So Foley's catheter is something you'll never try and put in a patient who has blood at meatus and inability to pass urine, because in case he has a partial rupture and you put a Foley's, you're going to convert it into a complete rupture. So you never want to put a Foley's. That's the first point. So now can I say that if Foley's is contraindicated, by extension MCU is contraindicated, because we just saw that the first step of MCU is putting a Foley's. So this is where both of these are out. They'll be in your options and it's just ruled out straight up. So what do you want to do next? So the next step is the investigation of choice for urethral trauma, which is RGU. So that is why we said that I'm not going to put Foley's, I'm just going to inject contrast. If I see this, it is normal. Now let's take a look at our patient. So this is the RG of a patient with urethral trauma. Is this normal? This is not normal. What is the part which is ruptured? So let's see. The horizontal part looks okay. So penile is fine. This is the bulbar urethra, where you can see that the contrast is extravasating and you can see it doesn't go further. So what is my diagnosis here? We are going to report it as a bulbar urethral rupture. Yeah. So now what next? So this patient is saying, doctor, I have one problem in life. I want to pass urine. You please find some alternate route for it. So what is the alternate route we put? We put a SPC. What is SPC? SPC is a suprapubic cystostomy, meaning you directly puncture the bladder above the pubic symphysis, that is suprapubic cystostomy, and the problem is solved. The only thing you want to remember, what if the patient says that my bladder is not full, or you try and palpate and they give you that the urinary bladder is not palpable. Now, can I rupture the bladder directly if it's not distended? I can't. So that is where what do? Nothing much. You ask the patient to wait. You're going to ask him to drink water and wait. Once the bladder becomes distended, that is when you go ahead and do an SPC. Understood? So this is what has been tested multiple times. Very, very important approach to urethral trauma. The recent favorite is bladder trauma. 2 to 3 years back, they were obsessed with urethral trauma. Now they are obsessed with bladder trauma. So here what you want to remember, first of all, what is the investigation of choice? That is CT cystography. So CT cystography is the investigation of choice, wherein again the process remains very similar to an MCU. The first step is you put a Foley's and now you're going to inject around 300 ml of contrast mixed with saline. Then you stop. You don't ask the patient to micturate. I now follow it up with a CT scan. So that is where I'm going to see this sort of an image. Now, if everything is normal, you're going to see the contrast remains in the bladder. But if there is any leak, now the contrast is going to extravasate. So that's what we got to see. What is the pattern of leak here? So you can see this is the bladder and the white contrast is around the bladder. So when you see this flame sign, like a flame, it's around the bladder, or some people call it like a molar tooth. So when you see this flame or molar tooth appearance, in short, when you see that the contrast is perivesical or in front of the bladder, Pre-vesical. This type of bladder rupture is what we call as extraperitoneal bladder rupture. This extraperitoneal bladder rupture is the most common type of bladder rupture, and the management is conservative. You just have to put the patient on Foley's and the patient eventually recovers. But the more dangerous type is this one, where what do we observe? We observe that our contrast has now leaked on into the peritoneal space. You can see it surrounding the bowel loops or in the perihepatic space. So this is the one which is the intraperitoneal bladder rupture. It is not very common, but once it happens, this becomes an indication of surgery because the urine is leaking into the peritoneal space. So this is what is the approach to bladder trauma. If the contrast is around the bladder, it's extra. If it is going here and there, sometimes the image may not be very good. They might also give you an X-ray cystography, an X-ray instead of a CT. In that case, you'll see the contrast going here and there. But remember, here and there. If the contrast goes around the bowel into the peritoneal space, that's intraperitoneal bladder rupture. Yeah, few more bladder appearances. What is this? You all know it looks like a Christmas tree. The bladder is vertically oriented with these multiple diverticulae. So Christmas tree bladder with multiple diverticulae around it. What is this? This is what is our neurogenic bladder. So this is neurogenic bladder, Christmas tree with diverticulae. Look at this cystogram here. You can see that the bladder looks like a teardrop. The bladder looks like a teardrop, or some people call it a pear-shaped bladder because it is being compressed. What is compressing the bladder? Anything in the pelvis. So it could be a fat overgrowth of the pelvis called as pelvic lipomatosis. It may be a pelvic hematoma. There will be multiple pelvic lymph nodes. So any cause of extrinsic compression of the bladder will lead to this teardrop or pear-shaped bladder. Look at this image here. You can see this white calcification surrounding the bladder or in the bladder wall. This has been called as the fetal skull appearance. This fetal skull appearance is what we see in schistosomiasis. So schistosomiasis can lead to calcification of the bladder wall. Remember, this is a risk factor for squamous cell carcinoma. S for schistosoma, S for squamous cell. I hope you remember bladder schistosoma is S hematobium. Remember terminal spine. Yeah, so that is schistosomiasis. What is this here? So now I'm showing you an ultrasound of the bladder, urinary bladder, and then what do we see? Same old stones. Remember gallstones. So now urinary bladder, you can also see these stones here. So these are our UB stones. They frequently are calcified. So when we look at the X-ray, can you see this? This appearance like a star or a snowflake is what has been referred to as a jackstone appearance. So this jackstone appearance is characteristic of a UB stone. You frequently get this question wherein they'll give you this is a post-menopausal female. First of all, is this a UB stone? Everything in the pelvis is not urinary bladder stone. What does a female have in the pelvis? A uterus. Sometimes a fibroid can grow to great sizes, and as menopause happens, the fibroids tend to undergo atrophy with calcification. So first of all, why is this not a bladder stone? Two reasons. A bladder stone will be in the center of the bladder. It won't be off midline. Secondly, it will be completely calcified. If you see closely, you can see there is this lamellated, stippled sort of a calcification, more like a soft tissue mass developing calcification, right? So this is what is a calcified fibroid. So I wanted to discuss the three main DDs of a pelvic calcification. You may see peripheral wall calcification of the bladder, that's schistosoma. You see completely calcified stone, that's a UB stone. Lamellated, stippled sort of appearance, that is calcified fibroid. The history in each is going to be very, very important. With this, we go on to the ultrasound, early pregnancy ultrasound. What are the ultrasound features of an early pregnancy? So what you need to remember, the earliest feature or the first sign of a pregnancy is a gestational sac, a G-sac, which is going to appear as this black fluid-filled sac within the uterus. So this is what occurs slightly off midline. Can you see this is the midline? It's white is the endometrium, and what you see surrounding the endometrium is the myometrium. So this is anterior myometrium, this is posterior myometrium. You can see this fluid-filled sac slightly off midline, and this is what we call as the intradecidual sign. As the G-sac grows, it is going to be surrounded by two different decidua. For example, if this is the sac, there are going to be two decidua capsularis and paritalis. Capsularis and paritalis, CP. Yeah, so capsularis paritalis surrounded, and that is what we call as double decidual sign. So both intradecidual sign and double decidual signs are signs of gestational sac. When is the earliest that you can see a G-sac? That happens to be 4.5 weeks. So you want to remember, close to 4.5 to 5 weeks is when we will see it on a transvaginal sonography. If you ask me, ma'am, what about transabdominal sonography? Only add 1 week, always. Don't remember both numbers. Just remember TVS, you're going inside the vagina to look at the uterus more closely. You will precede it by 1 week. So TVS versus TS, TVS is always ahead by a week. Okay, so we remember only one value. TVS is 4.5. If they ask me TS, I just add 1 week to it. Yeah, so the earliest an intrauterine pregnancy can be detected is 4.5 weeks. So now we call this patient after a week that, okay, I'm seeing G-sac, we'll confirm it in a week. So in 1 week, what you are now going to see is the G-sac, which is the gestational sac, grows, and within it appears a yolk sac. So can you see this black gestational sac with a central ring? That is the yolk sac. So yolk sac appears when? 1 week later, right? So on TVS, you want to remember 5.5. Yes, at 1 week. We call her, come back after 1 week. Now what do you see? We see that, okay, G-sac has grown further. This is the yolk sac, and what appears is now the embryo or the fetal pole. So this is the embryo or the fetal pole. The earliest you can see this on an ultrasound is 6.5 weeks, 1 week later. So you remember 1 week, 4.5, and then you just keep adding 1. Don't remember all values, okay? So 6.5 weeks, we see the embryo and the fetal pole. In a few days, what we are going to see is the cardiovascular system. The first system to develop starts to beat, the heart beats. So we see the fetal heart rate, the fetal heart beating at this point. So if they ask you, when do you see the fetal heartbeat? The earliest is 6.5 to 7 weeks. All right. This is the surest sign of viability of a pregnancy. Very, very important. You know, in gynae obs, you would have studied there are signs like Spalding sign, signs of intrauterine death, right? Where the sutures overlap. You have Roberts sign where there is air in the aorta. All of these are very late signs. The surest and the earliest sign that there is intrauterine demise or there is no viability of the pregnancy is when you don't hear the fetal heart beating. When will I pick it up? I can only pick it up after 6.5 weeks, right? So after 6.5 weeks, the surest sign of viability of a pregnancy is fetal heart beating. Did you understand that? As we go ahead 1 week later, now what you see, this has been asked frequently as a one-liner. This is what we call as the double bleb sign. So this is the double bleb sign. Don't confuse it with double decidual sign. What are the two blebs here? First of all, this largest sac is G-sac. Yeah. So you can see here, this is the embryo and there are two sacs. Now you can't really say which is yolk sac, which is amniotic sac, and there is no need to as well. But in this case, This is actually the amniotic sac and this is the yolk sac. Doesn't really matter. So what you need to remember that the baby is going to be surrounded by the amniotic sac and this is our yolk sac. Okay. So this is what you need to remember, that the two blebs here are the amniotic sac and the yolk sac. Frequently, the options will say G-sac, yolk sac. Those are not the two blebs. It's amniotic sac and the yolk sac, right? So this is what is the evolution and you get many questions from these. Next, we go on to the approach to enlarged ovaries. So whenever you see enlarged ovaries, you have to ask yourself a question. Ovaries are enlarged, but what about the follicles? So look at the first case wherein the ovary volume is increased, right? So this is where you have bulky ovaries, increased ovarian volume, but look at the follicles. The follicles are small and arranged in the periphery like a string of pearls. So this is what is called as string of pearls sign or a pearl necklace sign, where you see multiple follicles, multiple small follicles arranged in the periphery. How many and how small? Remember the number 10. Volume more than 10 cc. Follicles more than 10 in number. Size less than 10 millimeters. So number 10 does the job. Now there are many papers which say you should consider more than 12. There are many which say more than 20. In practice, it doesn't matter. As a radiologist, I'd never count the number of follicles if I have to make a diagnosis of, what are we talking about? We're talking about polycystic ovarian disease. So actually, we don't really count the follicles. We look at the gross picture. What is the hallmark is there should be no dominant follicle. The multiple small follicles actually tell me what? The pathology in PCOD is that there is an ovulation. So the hallmark here is the number doesn't really matter. It's that there should be no big follicle. There should be no dominant follicle. Dominant follicle is every cycle, one of these follicles in a normal female will enlarge and that would ovulate. That's not happening in PCOD. So that's why all of these are tiny, tiny follicles arranged in the periphery. 10 is just easier to remember. So that's what we remember. Fine. So that's PCOD for you. In addition, can you see how the stroma here, that's another specific sign of PCOD, that the central stroma is increased in volume and it is increased in echogenicity, meaning it is hyperechoic. So the very specific sign of PCOD is stromal volume increasing, and that is what leads to hyperthecosis. There is more androgen production from the stroma here. So this is the appearance of PCOD. But when they tell me that there are enlarged ovaries with enlarged follicles, now the follicles are also enlarged. Now you have to look at the history very carefully. If they tell me this is a female who's undergoing ovulation induction or some sort of in vitro fertilization, it means the diagnosis is OHSS. What is OHSS? Ovarian hyperstimulation syndrome. The drugs that you were giving, maybe clomiphene citrate, maybe beta-HCG injections, have stimulated the ovaries too much, resulting in these large follicles. A very similar appearance you shall also see when you have a molar pregnancy, right? Remember the snowstorm appearance in molar pregnancy. Now, molar pregnancy produces very high amounts of beta-HCG. Because of that, again, the ovarian volume will increase here and same appearance is going to be seen in theca lutein cysts. So theca lutein cysts are the cysts within the ovaries, bilaterally bulky ovaries in a case of molar pregnancy. So you want to remember 3 DDs of enlarged ovaries. When the follicles are small, it is PCOD. When the follicles are large, look at the history. History of IVF means OHSS. History of molar pregnancy means theca lutein cyst, right? Let's look at the questions from this. So here we have an RGU. They are asking us the finding. Let's see the RGU first. You can see that the penile urethra is normal. This is the level of the bulbar urethra. And what can we see? The bulbar urethra, instead of tapering normally in the distal part and almost involving membranous as well, has a stricture. So the better answer here is a bulbar stricture, right? So we see a bulbomembranous junction / a bulbar urethral stricture. Straight up, before reading this long history only, do you recognize the image? Medullary pyramids, calcification. So this is medullary nephrocalcinosis. With this background, let's read the question. 30-year-old male, fatigue, urination, increased thirst, weakness, discomfort. All of these findings are suggestive of hypercalcemia. Do you remember moans, bones, groans? So hypercalcemia has these signs. Can you think and tell me why polyuria, polydipsia? Because hypercalcemia, remember, is a cause of nephrogenic DI, right? So both hypokalemia and hypercalcemia can actually lead to nephrogenic DI, and that is explaining the symptoms. So this is actually a cause of hypercalcemia. You know, hypercalcemia leads to medullary nephrocalcinosis. So the best answer here is hyperparathyroidism. None of the others have any association with nephrocalcinosis. What do you think is the diagnosis? 45-year-old banker with vague abdominal pain, renal mass lesion, CT is being shown to you. I see the color black. When you see a black renal mass matches with the fat density, can you tell me the answer? We have to look for fat. We find lipo. It is angiomyolipoma. I hope you have no doubt here. 45-year-old female, presents with abnormal uterine bleeding. The ultrasound is shown to you. What are we seeing? We're seeing that within the endometrium, there is this vessel. This is a Doppler. We are seeing a feeding vessel sign. So this feeding vessel sign is indicative of a polyp. A polyp has a fibrovascular stalk. So that is what is this feeding vessel sign. It is suggestive of an endometrial polyp. Next, 34-year-old lady using OCP since 5 months, presents with amenorrhea. Now she was on OCPs. There is no last menstrual period in this case. So what is the gestational age? So you want to remember the best for gestational age, particularly in females who have irregular periods, who has forgotten her last menstrual period or is on OCP, is going to be the crown rump length. So as the embryo grows, right? So imagine this is the embryo. These are the legs. These are the hands. All right, very primitive looking embryo, but that's fine. So what you take is the length from the crown to the bottom of the buttocks. So this length here is called the crown rump length, and that is the best measure of gestational age. Remember, the gestational age is best in the first trimester. As you go on in the pregnancy, the accuracy of the gestational age on ultrasound keeps decreasing. So the best parameter is on the first trimester by crown rump length. This is a hysterosalpingography where you inject contrast into the uterus. You can see this is the normal uterus. The normal tubes look like this and then they have spilling of contrast. But in this case, there is no spilling. You can see that the tubes, the distal part of the tubes have become this dilated, retort shaped tubes. This is nothing but hydrosalpinx. This happens when you have obstruction at the distal end. The spill is not happening. The contrast is not spilling out because of obstruction. So this is bilateral hydrosalpinx. This is not normal. Normal will have a spill. What is cornual block? Cornual block is where here, this is the cornual end. This is where you will not even see the tubes, right? So that's how corneal block will appear. Asherman syndrome is where you have synecdoche. So within the uterus, you're going to see these filling defects here. In this case, the uterus appears just normal. So that is what you have to remember here. Look at this HSG now. So first of all, can you see this metallic catheter? When you see this catheter is the leach Wilkinson's catheter or cannula, which is used for putting dye. Nowadays, we don't prefer Leach Wilkinson. We either use a Carman's catheter or a pediatric Foley's. But either ways, this is Leach Wilkinson. And what you can see is only one horn. The triangular shape is not there. I can only see one horn of the uterus. And this is what is unicornuate uterus. So this is a Mullerian defect, unicornuate uterus. So with this, we complete genitourinary radiology. What we have next up is going to be thoracic radiology. Very, very important. Lots of important image-based questions are going to come from here. So beginning with the first chest X-ray here. When you look at the chest X-ray, first look for a side that is white or opaque as we call it. Whatever side has the opacity is definitely abnormal. So that's always the first step. The moment you see one side is opaque, your job is done. That okay, it must be which side in this case? Left side. Yeah. So right, left, never a confusion. So this is right and left. So on the left side, you can see there's an opacity and you can see that it has this rising curve laterally. So this is what is called as a meniscus sign or an Ellis's S curve, right? Where the peak is lateral. Whenever you see something like this, the diagnosis is pleural effusion. Pleural effusion is fluid within the pleural space. Now, if this is just fluid, that is what we call as a hydrothorax. But in context of trauma, this is what you may also call as hemothorax. Everything is going to be same radiologically. Whether it is blood, whether it is chylothorax, whether it is hydrothorax, it all looks the same on radiology. So it's the history that will tell you whether it's pleural effusion or it's hemothorax, right? Sign. The sign, as we discussed, is the meniscus sign, also called as Ellis's S curve. The earliest finding that you're going to see, this is a lot of fluid, right? So you can't really wait for so much fluid. The earliest sign that you will see, the fluid, when you are in a standing position, erect X-ray, what is going to happen? This is the angle. This angle here is the CP angle. What CP angle? Costophrenic angle. So this is what we call as the costophrenic angle, usually is sharp. As the fluid keeps accumulating, this is where the blunting of the angle begins and then it forms this entire meniscus. So the earliest finding on a frontal radiograph is going to be the blunting of this CP angle here. What will be the mediastinal shift? Anything which is space occupying in the thorax or the pleural space is going to push, right? Pretty logical. It's going to push the mediastinum to the other side. So we are going to see a contralateral mediastinal shift being pushed to the opposite side. The most sensitive investigation, what do you remember? Any fluid, it is ultrasound. So ultrasound is the most sensitive investigation that you have for fluid. What about the most sensitive? X-ray. So here I want to tell you some numbers also you may or may not remember. Overall, when we compare it with ultrasound, ultrasound can even detect 5 to 10 ml of fluid. It's the most sensitive. Compare it with the X-ray. The most sensitive X-ray here is ipsilateral lateral decubitus. Meaning, if I'm suspecting fluid on the left side should be down. So when the left side is down, the fluid will gravitate and it will form a horizontal level. So ipsilateral lateral decubitus is the most sensitive X-ray. Following this, the next in order is going to be, in terms of sensitivity, the next is a lateral X-ray, where you are on the side and you see the anterior posterior CP angle. That is more sensitive. Then a chest X-ray PA erect view, where the patient is standing, the most common one that you see here, followed by supine. Supine is the least sensitive radiograph. Supine X-ray to show you an opacity. You will just see a diffuse whiteness there, right? So for a supine radiograph to show you an opacity, we'll need somewhere close to 500 ml of fluid, which is a lot. A chest X-ray PA erect view will need somewhere close to 200 to 250 ml fluid. A lateral radiograph is much more sensitive. It will detect around 75 to 100 ml fluid, whereas ipsilateral lateral decubitus can detect close to 25 to 50 ml. So you don't really have to memorize these values. It's always a range, and these figures are also given slightly variably in different sources. But as a range, you want to remember ultrasound followed by lateral decubitus, followed by lateral, chest X-ray erect and supine. This is the order of sensitivity for fluid. Now, what I want to teach you here is very, very important. This is an approach to opaque hemithorax. Whenever you have one side lung which is completely white, there are three main possibilities. You have to look at the mediastinal shift in order to distinguish. So, look at the first image. You can see that this right side is completely white. And how is the mediastinum? You can see it is being pushed. There is contralateral mediastinal shift. In this case, the biggest possibility you want to keep in mind is a massive pleural effusion. So when you have massive pleural effusion, the entire lung is going to be opaque and you see a contralateral shift. Look at the second image. The second image, you can see the left side lung is opaque and you can see that the mediastinum, the trachea, is being pulled on the same side. So when you have ipsilateral mediastinal shift, it is either collapse. What is the meaning of collapse? It means that now, because of some obstruction, maybe this is a mass, there is a bronchogenic cancer occupying the main left bronchus. So what's going to happen? Complete lung is collapsed, total collapse, total obstruction. In that case, why is the lung white? Because the air of the alveoli is gone. So it appears white, but because there is volume loss, there is ipsilateral mediastinal shift. So one possibility is collapse. The other possibility is pneumonectomy. Maybe the patient underwent surgery. Yeah. So in that case, you will have history. So this is the second possibility. And the third possibility is where there is no shift. This is where you see opacity. Now, very rarely will it be a complete hemithorax. It will usually be a lobe. So this is what is a consolidation. So consolidation is an opacity where alveoli are filled with pus, right? So pneumonia is a consolidation. The alveoli is filled with pus. In that case, you'll have one lobe, lobar consolidation, and there is no mediastinal shift. So opaque hemithorax, pushing mediastinum is pleural effusion. Pulling mediastinum is collapse or pneumonectomy. No mediastinal shift is consolidation. Very, very useful approach. Now look at the other image. Very, very important. So now when we look at this X-ray, first of all, just a bird's eye view, you don't really see any opacity. So now look for the side which is more blacker. When you don't see anything white, now look, is there something extra black? There is. On the right side now, can you appreciate that there is a hyperlucent lung field? So when you see this hyperlucency, extra blackness, this is pneumothorax. This is where now the pleural space is filled with air. You'll ask me, ma'am, why can we see it as more black? Because lungs also have air. Why is this extra black? The lungs are black because they are filled with air, but they also have these bronchovascular markings. This appears extra black because this is in the pleura where there are no bronchovascular markings. So this is what appears hyperlucent, meaning extra black, because there are no bronchovascular markings. Did you understand this? So hyperlucency without markings is pneumothorax. What will be the mediastinal shift? Again, it will push the mediastinum to the opposite side. Contralateral shift. Most sensitive investigation. So anytime you want to see air, just like anytime you want to see fluid, it's going to be ultrasound. Anytime you want to see air, it is going to be a CT. So CT is the most sensitive investigation here. The most sensitive X-ray, remember, for a pneumothorax is an expiratory chest X-ray. What does this mean? So normally when I take chest X-ray, it's always an inspiratory view that we are going to take, alright? It's always end inspiration. If you've ever seen somebody getting an X-ray or get it done yourself, we say that take a deep breath and then hold your breath, yeah? In Hindi, we say lamba saas andar lo or rok lo. Means we're going to take an end inspiratory view. Now, why do we do that? We do that because I want more air in the lungs. Here, I want a differentiation between pneumothorax air and lung air. isn't it? So here, don't you agree that if I make my lungs whiter, this gradation becomes even better? So how can I do that? I can do that by taking an expiratory radiograph. In an expiratory radiograph, the lungs themselves are going to become whiter, hence highlighting the blackness of pneumothorax, because pneumothorax is not going to change on an expiratory radiograph. That's going to remain as it is. So that's why expiratory chest X-ray can pick up pneumothorax. Getting it? Now, let's talk in terms of trauma. Now, what I'm teaching you is the basis of trauma pneumothorax. You have a patient who's undergone chest trauma, has pneumothorax. They will ask you what to do next. If the patient is in shock, unstable patient, this is what I call as tension pneumothorax. This shock is actually an obstructive shock because the outflow vessels of the heart are compressed by the mass effect. So this tension pneumothorax, remember, is a clinical diagnosis. It's not a radiological diagnosis. That's the first learning point. What do you do next? So when your patient is unstable, what you have to do is put in a needle. So needle thoracotomy is what you are going to do next. You're going to put a wide bore needle in the 5th intercostal space, mid-axillary line in an adult, and a 2nd intercostal space, mid-clavicular line in a child. Okay, so this is where you're going to put your needle. You don't just stop there. You're going to then go ahead and put an intercostal drainage tube. Intercostal drainage tube is put in the 5th intercostal space in the triangle of safety. Yeah. While I've talked about it, we've also seen this in BTR, but triangle of safety is going to be the 5th intercostal space below. You know how we used to study lady between two majors? So remember lady and one major, latissimus dorsi posteriorly, P major anteriorly. That's the triangle of safety. While I'm going into it, 5th intercostal space. Imagine this is the 5th intercostal space. If I ask you which point will you put your ICD? A, B or C? Or it doesn't matter. You have to remember the concept that the intercostal vessels and nerve run along the inferior border of a rib. So I will never go along the inferior border of a rib. I will go along the superior border of the inferior rib. So it's the point C where you're going to put. Don't memorize the line. Understand this image and you will never forget it. So vessels run below the inferior border of the rib. So I always have to go along the superior margin of the inferior rib, right? But if the patient is stable, all I have to do is put an ICD directly. So this is the management of pneumothorax. Next, we're going to learn about EFAST. Remember how we said EFAST is done in trauma. Extended fast can be used in thorax to evaluate pneumo and hemothorax. Now, I also said that air is the enemy of ultrasound. Yeah. So then, ma'am, how can you detect pneumothorax? That is because I am not actually trying to see the air. We have the two layers of the pleura. They are sliding one over the other. So this is the parietal pleura. This is the visceral pleura. They are sliding. So I am actually trying to see that motion. If there is pneumothorax, the sliding stops. So that's why I use this special mode of ultrasound called as M mode ultrasound. M for motion. Look at this. When we see that there are these lines, and then there is this granularity. This is what we call as the seashore sign. These are the waves of the ocean and this is the beach. When do you go to a seashore? When do you go to Goa? Do you go during exam time or do you go during normal times after exam? We go during normal times. That's the correct answer. So seashore sign is seen in normal lung. That's how you'll remember. But look at this image. No beach whatsoever. All I see are just lines. So what is this? This is what has been called as barcode sign, also called as stratosphere sign. So this barcode or stratosphere sign is what we see in pneumothorax. So seashore sign, normal lung, barcode or stratosphere seen in pneumothorax, right? So that's how we can detect pneumothorax on ultrasound using the M mode ultrasound. Now I'm going to show you few x-rays which are confusing again, and all of these have one horizontal level that you can appreciate. So let's understand the difference. First of all, I wanted to look at the second image here. We studied hydrothorax, we studied pneumothorax. What if there is both? In that case, the entire pleural space is now going to have what? It's going to have this level. So this is the fluid, this is the air fluid level. So horizontal air fluid level in the pleural space is hydropneumothorax. You're going to put an ICD next. So this is sorted. Now another air fluid level, but now it's a rounded lesion in the lung which has an air fluid level. So this is actually an abscess. Abscess has pus which settles and air which is above. So this is a lung abscess, right? Look at the third image. Is this hydropneumothorax? It can't be hydropneumothorax. This is below the diaphragm. So what is this? Is this even abnormal? No, this is nothing but the stomach. Our stomach normally has air. We have seen that. But then why is the stomach in the thorax? The stomach is in the thorax because of a diaphragm injury. So in context of trauma, this image represents a diaphragm injury where the stomach has been pushed into the thorax. So here the diagnosis becomes diaphragm injury. This has been asked very smartly once. They gave this image and they asked, what is it that is contraindicated in this patient? And ICD was the answer. Will you ever put an ICD? Few of you might have thought that, oh, this is hydropneumothorax, this is air fluid level, you go ahead and put an ICD. Patient already has a diaphragm injury, now you've just created a stomach perforation. Never ever do that. So this is where you have to recognize that it's stomach, it's below the diaphragm, it has been pushed up into the thorax because of diaphragm injury, right? Now look at this. Where is the air fluid level? It is behind the heart. So whenever we see a retrocardiac air fluid level, this actually represents the herniation of stomach into the midline. How does that happen? So this is a hiatal hernia. This is the herniation of the stomach via the esophageal hiatus. Which type of hiatal hernia? So you know there are two types. There is sliding hiatal hernia where only the GE junction comes up, and then there is the rolling type of hiatal hernia where G junction stays put and rest of the stomach comes up. Which one do you think this is? So when I see this air fluid level into the thorax, this can't be sliding because there only G junction is coming. I can see the entire fundus up here, isn't it? So this one is the rolling type of hiatal hernia, right? So these are the 4 air fluid levels we need to know. If it's a lung lesion, it's an abscess. If it's the pleura, it's hydropneumothorax. If it's stomach coming up into the thorax, that's diaphragm injury. And when it's in the midline, that's a hiatal hernia, right? This is where I've seen most of the students getting confused. Moving on now to consolidation. So whenever you see an opacity, right, an ill-defined confluent sort of an opacity, that is what we call as a consolidation. Here you frequently get asked, where is this consolidation located? So now right upper lobe is pretty clear, it will be up there. But middle and lower lobe, because X-ray is a two-dimensional investigation, tend to overlap. So that is where middle and lower can't be distinguished just on the basis of the location. So this is where we need to understand something that is called as the silhouette sign. What is the silhouette sign? So silhouette sign you need to understand is to learn the demarcation between two structures. So I'll explain further. You can see there is an opacity here. Can I know definitively the difference between this opacity and the heart border? I can't really. Both of them are merging into one another. So when you see that an opacity obliterates the heart border, we cannot distinguish the opacity from the heart border. It is in the middle lobe. So when it silhouettes the right heart border, it's the middle lobe. right middle lobe. If it silhouettes the left heart border, it is in the lingula. So we don't have a left middle lobe, so we call that as lingula. So did you understand? Silhouetting right heart border is right middle lobe. Silhouetting the left heart border is lingula. If something silhouettes the diaphragm, that is the right lower lobe or the left lower lobe. So if you see silhouetting of the diaphragm, that's lower lobe. If you see silhouetting of the heart border, it's middle lobe. That's how we use the silhouette sign. So just to make sure you've understood, now look at this X-ray here. Can you tell me this opacity is middle lobe / lingula or lower lobe? So it's on the left side. So either it's lingula or left lower lobe. What do I see? Can you appreciate here that the heart border can clearly be distinguished from this opacity, and it is silhouetting the diaphragm. I can't really see the diaphragm contour. So where is this located? Very nice. This is in the left lower lobe. Did you understand? So now see first and third X-ray together. Middle lobe, silhouetting heart border. Distinct heart border, lower lobe. Right? So that is how we apply the silhouette sign. Another way to distinguish is to see a lateral view. If they give you lateral radiograph, look here. If an opacity, can you see this is the opacity here? If an opacity overlies the heart, this is the middle lobe. This is how the fissures are oriented, right? So this is usually the horizontal fissure, and this is how you're gonna have the oblique fissure. So this is the middle lobe. If you have an opacity occupying the lower lobe, this is the position it will be in. It will obliterate the spine. So that is what we call as the spine sign also. So if something overlies the spine, that's lower lobe. If something overlies the heart, that is middle lobe. So this is what is the silhouette sign for localization of a consolidation. In addition, look at the third X-ray now. We already see that there is a left lower lobe consolidation. You can also see that there is an air-containing lesion here. So there is an air-containing lesion here. This is what is called as a pneumatocele. So we have here a left lower lobe consolidation with a pneumatocele. A pneumatocele is a classical finding of a Staph aureus pneumonia. Right? Most of the pneumonias, the lobar consolidations are caused by pneumococcus. S. pneumoniae is the most common cause of lobar pneumonia. Pneumatocele is the hallmark of Staph aureus pneumonia. Right? So that's what you want to see here. Further going ahead into HRCT. Do you remember when we began our discussion of rapid revision, we said that high resolution CT is the investigation of choice for any respiratory pathology. So for any infection that you want to see, we are going to look at HRCT. So that's what I'm going to show you. I'm going to show you lots of HRCTs. All of them are presenting to you with features of infection. We see the CT and we diagnose. So look at the first image. Bilaterally, you can see that there is complete opacification. We can't see the underlying lung at all. And you can see that the bronchus has air. So when you see this sort of an appearance, this is a classic consolidation, hallmark of a lobar pneumonia. So this is a consolidation, and this sign is what we call as the air bronchogram sign. It represents that the alveoli are filled with pus, but the bronchus is normal, right? So the bronchus leading up to it is filled with air, but the alveoli being filled with pus or fluid are going to be opaque. So this is consolidation with air bronchogram sign. Repeat, neat question. Looking at the second image, you can see that this is where a bronchus is having these nodules. You can see that along the bronchus there are these nodules, and this is what we call as a tree in bud appearance. It looks as if there is budding along a tree. So this tree in bud carries the answer in the name itself. So this is what you see in active tuberculosis. It represents TB, which is present within the bronchus. So this is what represents active TB, endobronchial spread of TB. And this pattern, you may hear one more name that is called as centrilobular nodules. So just remember, this is TB which is active, it's within the bronchus. tree in bud is endobronchial spread of tuberculosis. Look at the next image. Again, patient with chronic recurrent cough. What do we see? Now, normally, when you see these white lines on the HRCT, they are the bronchovascular bundle, as we said. Normally, the artery and the bronchus, both of them are the same size. Yeah, both of them have the same size. But when there is bronchiectasis, now the air-filled bronchus will enlarge, artery remains as it is. So this is what gives rise to the signet ring appearance, and that indicates that the bronchial tree is dilated, called as bronchiectasis. So bronchiectasis, remember, is the irreversible dilatation of the bronchi. Look at this image. This is the artery. This is the thickened bronchus. So this image is bronchiectasis. Yeah. So for all of these, remember, anything pulmonary, investigation of choice is always HRCT, like we have seen. Look at the next image. This is where they will tell you that this patient is immunocompromised. So either they will give you a person who's having HIV/AIDS, or they will give you this person is on chemotherapy. They use a term called as febrile neutropenia. So a neutropenic patient who has fever, and you see this CT where you can see that there is a solid nodule with surrounding ground glass opacity. So look at this. Center is solid with a peripheral GGO. What is GGO? Ground glass opacity is when you see an opacity in the lung, but it is not as white as consolidation. Can you appreciate this? This is consolidation, completely white, can't see the underlying lung. But if you can see little underlying lung, that is ground glass opacity. Can you understand this? So this actually, have you seen these glasses where you can see that somebody's inside, but you can't exactly see what's going on? That's ground glass. So when you see this solid center with peripheral halo of ground glass opacity, this sign is referred to as halo sign. So these multiple solid nodules surrounding GGO, this is diagnostic of invasive aspergillosis, particularly in the context of this immunocompromised patient. Very, very important. You have angio invasion leading to bleeding, and it's this bleeding actually which gives rise to the ground glass opacity halo. Fine. So this is aspergillosis. Don't confuse it with an aspergilloma. This mistake also I've seen a lot of students do, is to confuse aspergilloma and aspergillosis. Aspergilloma is a fungal ball. You'll have a cavity. Usually cavity comes from TB sequelae. Within the cavity, you have a fungal ball. It is not an invasion. It is a saprophytic infection. So this is a fungal ball within the cavity. That is what is called as an aspergilloma. Fine. So this is what we need to remember. They are not the same. Aspergilloma will affect patients with TB cavities, not immunocompromised patients. All right. On the other hand, look at this image now. Here, you can see the opposite. You can see a reverse halo, isn't it? So reverse halo sign is where the periphery is solid and the center is where you see the ground glass opacity. So this is reverse halo. Context we can see this. One, if you see again an immunocompromised sick patient, this reverse halo sign can be seen in mucormycosis, pulmonary mucormycosis. But if you have a patient who's not sick at all, in context of an interstitial lung disease, another DD, ILD is actually an organizing pneumonia. OP. This was previously called as cryptogenic organizing pneumonia, COP. Now we call it organizing pneumonia. So two cases of two DDs of reverse halo sign, mucormycosis versus organizing pneumonia, right? So we've done halo, we've done reverse halo. So now look at this HRCT here. Is this consolidation or is this ground glass opacity? So here, can we see the underlying lung? That's the point I want you all to understand. So this is where you can actually see the underlying lung. It's not as white as consolidation. So this is what we call as GGO. I'm sure during the pandemic, all of you have seen these multiple reports of HRCTs saying GGO, right? So ground glass opacity, when you see these multifocal, so when I see these multifocal peripheral ground glass opacities, this is what is the hallmark of COVID-19. So COVID-19, the hallmark is multifocal peripheral GGOs. This is what we call as typical COVID-19. We used to give a score of COVID-19, which is CORADS. Typical COVID is CORADS 5, right? So that's what you need to remember. A normal HRCT, it's CORADS 1. 2 is where it is a benign finding. 3 and 4 are equivocal. 5 is typical COVID-19. 6 is where the patient is RT-PCR positive. Just remember, typical finding, multifocal peripheral GGOs. Look at the next HRCT. We can see that there are multiple small millet-shaped nodules. This is what we call as the miliary nodules. So miliary nodules, remember, the first possibility in case of fever, infective symptoms is always tuberculosis. But there are various DDs to it. What are the other causes of miliary nodules? Once this was asked that a patient has miliary nodules and there is eosinophilia. In that case, you have to think of Loeffler's syndrome. Loeffler syndrome, also called as tropical pulmonary eosinophilia, in which case, you're going to have eosinophils with miliary nodules. So that's another DD. Then in varicella, healed varicella particularly may give rise to these miliary nodules. You may also see miliary nodules in histoplasmosis, which is a very close mimic of tuberculosis, right? So these are your various DDs you want to remember about miliary nodules. Look at this patient now. This is an interstitial lung disease. They'll give you spirometry findings, they'll give you rails, okay, so spirometry showing restrictive lung disease, and then what you are seeing here on the HRCT, can you appreciate these black things? This is what looks like a honeycomb. There are various cysts which are stacked one on top of the other. So this finding is what is called as honeycombing. So when you see this honeycombing, in addition, you can see that the bronchus leading up to it is dilated. That is what we call as traction. It's the fibrosis which is pulling the bronchi and making it dilated. This is what is traction bronchiectasis. And what you see is a lower lobe predominance, basal, lower lobe predominance. When you see this triad, this is what is the hallmark of UIP or IPF. UIP is what is the clinical radiological diagnosis, usual interstitial pneumonitis. Pathological counterpart of the same, both are synonymous, is IPF, meaning idiopathic pulmonary fibrosis. So just remember the short forms UIP or IPF. The hallmark is honeycombing, right? Moving on to the last HRCT that you need to know. So here we have a patient who is HIV positive with a CD4 below 200. Always keep an eye out for CD4 below 200. And then when you see this bilaterally diffuse involvement, so you can see this bilateral ground glass opacity. Sometimes there will be cysts also that can develop. Lung cysts will be air containing black lesions. So bilateral GGO cysts, this is the hallmark of PCP pneumonia. PCP pneumonia tends to affect HIV patients, CD4 less than 200. So that's why we have to give prophylaxis as well as treatment. Both of these are done with cotrimoxazole. So this is what is very important. Let's rule out. Can this be TB? No, neither is this strain bud nor is this miliary pattern. Pneumococcus is going to be a lobar consolidation, not bilateral GGOs. Aspergillosis we saw were halos. They were nodules with a halo sign. So this indeed is PCP, right? Next, I want to talk to you about edema, pulmonary edema. So when I say pulmonary edema, it can either be cardiogenic pulmonary edema means it is developing because of left ventricular failure. Or it could be non-cardiogenic pulmonary edema, which we also call as ARDS, acute respiratory distress syndrome, which could happen because of any other systemic cause, right? So we need to first distinguish the two. Let's talk about cardiogenic pulmonary edema first. What happens when the left ventricle fails? The blood overloads in the left atrium. From the left atrium, it goes back into the pulmonary veins. So essentially, the pulmonary venous pressure increases, the pulmonary veins begin dilating. So the earliest change that I see is cephalization. The pulmonary veins of the upper lobes become dilated as compared to lower lobes. As this pressure further increases, what happens is the peripheral pulmonary veins begin to get dilated. Those are present within what we call as interlobular septa. So this interlobular septa becomes thickened. These interlobular septal thickening on an X-ray looks like these horizontal lines. Can you see these horizontal lines? They are what we call as Curley lines. Curley lines are most commonly appreciated at the base of the lung. Can you see? This is the CP angle. So at the base, when we see these horizontal lines, these are the Curley B lines, okay? So these are Curley B lines. Curley A lines can be seen near the hilum. They are the oblique lines. So not important, but just remember B lines are more commonly seen at the base. So this is the second stage. After cephalization, we see this Curley lines. As the pressure further increases, now the fluid from the pulmonary veins goes into the alveoli and you start to have consolidations, and though they are going to be central. This is what we call as bat-wing consolidation, or perihilar consolidation. So these are the findings of cardiogenic pulmonary edema. Cephalization, Curley lines, perihilar consolidation. Can there be associated pleural effusion? Yes, we can have transudative pleural effusion. Versus ARDS. ARDS is going to have multifocal peripheral consolidations. That is where you have this patchy appearance, no central predisposition. Will I ever have Curley lines in ARDS? No, there is nothing to do with pulmonary veins. There will be no Curley lines. There will be no pleural effusion. So that is what is very, very important. ARDS versus cardiogenic. If you understand the pathophysiology and the concept here, you will not need to memorize it. Okay. So this is pulmonary edema. Going on into two places where you're going to hear the popcorn sign. So one, this is a mammography. Within a mammography, if you see a well-defined, they'll describe it as a breast mouse, and you see this popcorn calcification. This is what is pathognomic of a fibroadenoma. It's a benign breast lesion. On the other hand, if you see a popcorn calcification within a pulmonary nodule, this is what is a hamartoma. A pulmonary hamartoma, also called as a chondroma. Chondro meaning cartilage, is the cartilage which makes it white, the calcification. So hamartoma or chondroma, this is the most common benign tumor of the lung. So this is what you need to know about popcorn calcification, right? One more case, very, very important. So here you have a patient who comes to you with dysphagia. What can you see? This is the barium swallow. Can you appreciate that there is a posterior indentation of the barium column? How do I know posterior? Can you see the vertebra here? So this is a posterior indentation on the barium swallow. So that is the barium swallow finding. You do the CECT and see what we find. We find that this is the arch of aorta. Normally, arch has three main vessels. What are the three vessels of the arch? From right to left, we have three arteries. Brachiocephalic artery, which further divides into right common carotid and right subclavian. We have the left common carotid and the left subclavian. You can remember as Budd-Chiari syndrome. This is an anomaly where you have aberrant right subclavian artery, ARSA. What is aberrant right subclavian artery? Here, there is a fourth branch. You have right common carotid, left common carotid and left subclavian, and right subclavian arises as the fourth branch from the arch. Can you see this? And this branch courses behind the esophagus. So look here, this air containing structure is the trachea. Behind that is the collapsed esophagus. We have this vessel pulsating behind the esophagus and then going on to the right side to form the right subclavian artery. So this is why, because of the pulsation, this patient will have posterior indentation leading to dysphagia. So a vascular issue leading to a GI presentation. Very unique, very important. So this is what we call, this presentation is what we call as dysphagia lusoria, and you want to remember the cause as ARSA, which stands for aberrant right subclavian artery, right? Very important. Looking at the questions here, so we have a male presenting to trauma center with shortness of breath. Supine X-ray is shown. So on supine, we will not see the meniscus. You will see complete opacification. So what is it? Complete opacification, contralateral shift, hemothorax. Can this be pneumothorax? Never. It will have air. Can this be diaphragm injury? No, that will have raised hemidiaphragm. What is a contusion? A contusion is like a consolidation. Okay, it's a parenchymal injury to the lung. That will have one, just like consolidation, it will affect one lobe. It won't be diffuse. It will not have mediastinal shift. Okay, eggshell calcification is the hallmark of sarcoid and silicosis. This is where the lymph nodes have this peripheral rim of calcification. These are the two main DDs, but this may also be seen in post-radiotherapy. Any treatment, that you give to lymphoma, which is radiotherapy or chemotherapy, can develop this calcification, but this is not something you see in metastasis, okay? So that's the best option here. Which of the following is true regarding CORADS? CORAD 0 is not normal. It indicates incomplete or inadequate study which needs repeating. CORADS 5 is typical. That is true. And what is the typical finding? We saw multifocal, peripheral, ground glass opacities. Is pleural thickening typical? No. Is lobar consolidation typical? No. So as a general guideline, you want to remember anything which is typical in TB is not typical in COVID. Yeah, so consolidation, thickening, all of these are not typical of COVID-19. 45-year-old male presents to trauma center. What we see is diaphragm injury. I already revealed this answer. What is contraindicated? This is diaphragm injury. This is not hydropneumothorax. You will not put an ICD. 6-year-old child presents with hypertension. Lower limb pulses feeble, inferior rib notching. So inferior rib notching, what happens? This is coarctation of aorta. In coarctation of aorta, you have a narrowing here just distal to the ductus arteriosus. So because of which the blood to the lower limb is compromised, and that's why there is a brachiofemoral delay. There is feeble femoral pulsation. These are your buzzwords for coarctation of aorta. So how do I send blood to my lower body? So here you have a collateral circulation. The intercostal arteries open up and they pulsate, sending the blood to the aorta. We already saw that the intercostal vessels are at the inferior rib border. They become so dilated that they are now going to pulsate really hard and lead to inferior rib notching. That is your finding of coarctation of aorta. Silhouette sign. So independently, first look at this and tell me, is it lingular or is it lower lobe? Can you appreciate the heart border separately? We can't. So this is silhouetting the heart border. You can see diaphragm is seen separately. So this is left heart border silhouette sign positive, meaning it is in the lingula and location can definitely be commented. So this is what is lingula silhouette sign positive. Cattle handler, hemopsis, chest pain, what do you see? You see a cavity, and can you appreciate these membranes crumpled down? Remember what I told you when we were studying hydatid? This is the water lily sign in the lung, representing a pulmonary hydatid cyst. A pulmonary hydatid cyst, remember, does not calcify. Yeah. Next, 35-year-old female with Raynaud's phenomenon, tightening of the skin, bilateral rales. So all of the connective tissue disorders, remember in this case we are likely talking about scleroderma, have a risk of interstitial lung disease. That is what you're expecting when you see these rales and creps. What is the investigation of choice for ILD? You have already seen as HRCT. Echo, PFT, MRI will not help. It's HRCT chest. 54-year-old male, dyspnea, eosinophilia with miliary, not military, miliary mottling. What is it? Tropical pulmonary eosinophilia. Just that you don't have to be biased about TB. The moment you see miliary, don't mark TB. If it's eosinophilia, it's Loeffler syndrome or tropical pulmonary eosinophilia. So that is it for thoracic radiology. Next, we will move on to neuroradiology. So now beginning with neuroradiology, the first thing I want to discuss is the radiological anatomy. This is where you get questions, pointing at a structure and they'll ask you associated questions. So I'm starting with the most important level here, which is the level of the basal ganglia. Before I jump to the anatomy, the modality. What is this modality? Is this CT, MRI, ultrasound, X-ray? So you can see that the bone here is black and that means it's an MRI. We have already been through this for the brain, spinal cord, nerves. It's always MRI that we are going to prefer, right? So this is the MRI. And which sequence of MRI? So whenever you see that the water, the CSF is white, whether it's this image, or for that matter, this image, all of these are T2 weighted MRI. Okay, water is white, World War II. So first section, that's the level of the basal ganglia. These are the lateral ventricles. These are the frontal horns. These are the occipital horns. And what you see here in the center is the third ventricle. Yeah. So first of all, these are lateral ventricles and this is the third ventricle. On the two sides of the lateral ventricle, what is this nucleus that you can see here? So this is going to be the caudate nucleus. So what you see here on the two sides of the lateral ventricle is C for caudate nucleus, right? So that is the caudate nucleus. Then what you can see here as this lens-shaped nucleus is the lentiform nucleus. This lentiform nucleus, you can see the outer part is putamen, inner part is the globus pallidus. So putamen, globus pallidus is the lentiform. On the two sides of the third ventricle, what we have is the thalamus. So this is the thalamus and you can see here, this is the internal capsule. This is the anterior limb, genu and posterior limb. So this is the internal capsule right here. So this is what constitutes our basal ganglia. We'll keep adding on to this knowledge as we go along, but this is the bare minimum we need to know. As we go down, we have the brainstem. So if I ask you what part of the brainstem is this? Is it midbrain, pons or medulla? What will you say? You'll say this is the pons. First of all, pons is the widest part of the brainstem, right? What you have to do to identify is anterior to it will be the only unpaired vessel of the brain. And that is which vessel? This is the basilar artery. So basilar artery is the only unpaired vessel and that runs in the prepontine cistern. So this makes it pons and you can also see the fourth ventricle behind it. So that's how we identify. These are the two cerebellar hemispheres joined in the center by the cerebellar vermis. Right? So this is what is the level of the pons. Just to correlate on a sagittal view again, just finishing brainstem off. So this part here is the midbrain. Then you can see the bulbous part is the pons. And can you appreciate the vessel anterior to it? Vessels are going to appear as black on an MRI because the velocity of the moving blood is so fast that it cannot generate a signal. And that is what we call as a flow void, right? So we see the flow void of the pontine artery, or basically the basilar artery in the prepontine cistern, and you can see the fourth ventricle behind it. So that was the axial cut we had seen, and this thin part here is the medulla. So this is the fourth ventricle, this is the cerebellar hemisphere, and what has been marked is the cerebellar tonsil. Okay, so what has been marked here is the tonsil, cerebellar tonsil. Okay. Apart from this, what you can also observe here, this is the corpus callosum, right? So this is the corpus callosum. Corpus callosum is made up of 4 parts. Anteriorly, we have rostrum, then you have genu, body, and splenium. RGBS, rostrum, genu, body, and splenium is the posterior part, which is important. Fine. You can also see here, this is the sella. The sella is just above this sphenoid sinus, and that is where the pituitary is housed. And just above the sella, so if this is the sella or the pituitary, this is where you have the optic chiasma. So OC is the optic chiasma. That's why big sellar lesion, big pituitary lesions can compress on the optic chiasma, leading to bitemporal hemianopia, right? So this is about the relevant anatomy we need to know. Now jumping on to the most important topic, you usually get one question from this, and that is head trauma. So what you want to remember here, the investigation of choice for head trauma is NCCT. We've already been through this. Anytime I want to see acute hemorrhage, it's going to be hyper dense on a CT. It's going to be white, and that's why I do a non-contrast CT. Now we have to see the shape of the acute bleed in order to decide where it is located. So look at the first 3 images here. You can see that there is a crescent or a banana, whatever it is. So there is a crescent shaped hematoma. Here you will have history of some sort of trivial trauma, like an alcoholic who's taken a fall. There is old person who's fallen in the bathroom. So basically some sort of trivial trauma shall be mentioned, because this is acute subdural hemorrhage. Remember, SDH, subdural hemorrhage, is a venous injury. It's a bridging vein injury because of trivial trauma. Now, can it cross the midline? It cannot cross the midline, but it can definitely cross the sutures. That is why it has this shape where it can cross. This is where the sutures are located. So it can very well cross the sutures, but it cannot cross the midline. Yeah. On the other hand, there's this patient who has a history of a road traffic accident. What sort of a hematoma do we see? We see a lens-shaped, biconvex, whatever you want to call it, idly. So idly will help you remember EDH. So this idly shaped hemorrhage is acute EDH, extradural hematoma. This is because of an arterial injury. You will usually have a severe road traffic accident here. So this is because of an arterial bleed, and the most common arterial bleed here is the middle meningeal artery. It's the anterior division of the middle meningeal artery which actually tends to bleed here. Does it cross the sutures? No. The fact that it is idly shaped or lens shaped is because it is limited by the sutures, but it may cross the midline. So you want to remember either one of them and then just invert it for EDH. Okay. Now, this is not it. If we look at this CT scan carefully, you can also see there is one more white lesion here. Now, this is not an extra-axial bleed. Extra-axial means outside the brain, like subdural, extradural. They are meningeal bleeds, isn't it? This is an intracranial bleed, and when you have such a hematoma, this is what we call as a contusion. So, this is a hemorrhagic contusion right here. And is there a relation of them being diagonally opposite? Have you heard of something called as coup counter coup? Wherever there is impact of trauma, diagonally opposite to it, the brain is going to be bouncing back, resulting in another injury. So whenever you have EDH, there is always associated, not always, but usually associated coup counter coup mechanism. So we must always screen the area diagonally opposite to an EDH very carefully in case there is a small contusion sitting there. Okay, so this is about EDH versus SDH. If you have history of road traffic accident, or this may also be spontaneous, right? So spontaneously you may have a patient who's coming to you with a very, very severe headache. They may describe it as a thunderclap headache. Thunderclap meaning it increased in severity very, very suddenly. Also been called as worst headache of my life, right? So that is what you will have as a history in cases of spontaneous SAH. So what you see here is a star right? These are the basilar cisterns which are having blood. So this is SAH, standing for subarachnoid hemorrhage. So overall, the most common cause of SAH is indeed trauma. That is more common than aneurysmal rupture. So the most common cause of spontaneous SAH obviously is aneurysmal bleed, but overall trauma is more common. The most common site of these aneurysms are called as Berry aneurysms or saccular aneurysms. The most common site is at the junction of ACA, ACOM, anterior cerebral artery, anterior communicating artery junction. So anterior circle of Willis is the most common site where these aneurysms tend to form. When they rupture, they lead to subarachnoid hemorrhage. A syndrome with which these are associated is polycystic kidney disease, which is a condition associated with these Berry aneurysms. So you may get a question related to and linking both of these findings. Apart from that, once you have an aneurysm, now how do we treat it? So the preferred method nowadays is a coiling. So intravascular, endovascular coiling is what we do as interventional radiologists. You go in with a catheter and you put coils inside the aneurysm. So that is what is the preferred method of curing or treating these aneurysms. If you have a history of road traffic accident, they mentioned that the patient's GCS is very low. There was a very severe accident that happened, but the NCCT is normal. So they are saying that the NCCT is normal with such a low GCS and a severe injury. You were expecting a lot of bleeds. Or they mentioned that there are tiny bleeds, petechial hemorrhages. This is a classic clinical scenario describing DAI. DAI stands for diffuse axonal injury. So this is DAI, where what you're gonna have are these small bleeds called as micro bleeds. As the name suggests, this is not a vascular injury. This is where the axons are getting torn. This is because of a shear stress. There is shearing or pulling of the axons, which results in these small bleeds at the sites of trauma. So that is where CT actually will miss or underplay the diagnosis, and that's why MRI is the most sensitive. And the sequence we have already talked about is SWI, susceptibility weighted imaging, where you see wherever the axon has broken, there are these tiny foci of blooming, these black dots, which suggest micro bleeds. So that's diffuse axonal injury. Few more images related to trauma. So now when I show you this image, what do you think is the diagnosis? So we can see that there is a banana shaped hematoma. So this is subdural hemorrhage, but then what is different? The difference is this is not hyperdense. The SDH we had seen had to be hyperdense to be called as acute SDH. So then what does this become? Yes, this is a repeat question. This is chronic subdural hematoma, and you can see that there is a lot of mass effect. Can you appreciate how the brain is going to the other side? And this is what is called as a midline shift. So whenever you have a significant midline shift as such, this is what becomes an indication to operate. This is an indication of decompression, wherein you need to remove a part of the skull bone in order to decompress the brain. Another indication of decompression in this sign here, first of all, is this EDH or SDH? So you can see that it is limited by the sutures. It is not able to cross the sutures. So this indeed is EDH, but now look at the density. In the density, you can appreciate that there are both hypo as well as hyperdense areas. This is what we call as swirl sign. So swirl sign, when you have both hypodense plus hyperdense areas within a hematoma, and this is what indicates that there is actually active bleed which is going on, suggesting a poorer prognosis and an indication of decompression. So this is the swirl sign. What you can see here, you can see that the frontal lobes are peaking, right? First of all, you can see there is black air in the brain and the frontal lobes are peaking like a mountain. This is the Mount Fuji sign. This Mount Fuji sign indicates air within the brain, and this is pneumocephalus. So not air within the brain, but air within the intracranial system. So what you can see here is outside the brain in the extradural space, there is air. How did this air come inside the cranial cavity? Either there is some sinus like frontal sinus, mastoid air cells which are involved by a fracture, or there is an open fracture through which air is coming inside. So these are the two possibilities, and this is not just a pneumocephalus, this is a tension pneumocephalus because you can see the frontal lobes peaking here. So Mount Fuji sign, tension pneumocephalus. So this is what you need to know from head trauma. One of these always gets asked. Now look at this CT. When I look at this CT, again I can see a hyperdensity here. So I know it's an acute hemorrhage. But where is this acute hemorrhage? So now we know our basal ganglia anatomy, and from that you can tell me, ma'am, it's involving the lentiform nucleus. So this is a bleed in the outer part of the lentiform basically involving the putamen. So this is a basal ganglia bleed. Some people call it as gangliocapsular bleed because from the basal ganglia it extends into internal capsule, and the moment internal capsule is involved, particularly the posterior limb, you know all of the corticospinal tracts are arranged in the posterior limb of internal capsule. You have the entire body, we have learnt it in BTR, fatal. This is the arrangement of the internal capsule corticospinal tracts here. So face, arm, thorax and limbs. This is how all the body is in this much small area of the posterior limb of internal capsule. So the moment this gets involved by the bleed, you're going to have hemiplegia. So this is what is called as dense hemiplegia. That is how these patients present. And the most common site is putamen here, and this tends to affect patients who have hypertension. So the most common site of hypertensive bleed is the putamen, and the vessel is called as the Charcot's artery. The Charcot's artery is a branch of MCA. It is the lenticulostriate branch of MCA that supplies this part of the brain, and that can rupture here. So what happens is this artery has these small Charcot-Bouchard aneurysms. So Charcot artery, Charcot aneurysm. So these are microaneurysms which form, and they tend to rupture if there is a spike in the hypertension. So that is what is very, very important for putamenal bleed. If I show you this particular CT and I ask you, is this hemorrhagic stroke or is this ischemic stroke? Clearly it's not hemorrhage, right? So when you see this hypodensity here, this is what is an ischemic stroke. Now, ischemic stroke, they will ask you what is the vascular territory involved here. So this largest territory here is indeed the MCA territory. You know, MCA, middle cerebral artery, is the most common artery to be affected in an ischemic stroke. The anterior part here is the ACA territory. The posterior part here is the PCA territory. So this is an MCA territory ischemic stroke. On the other hand, what is this now? So this is also an ischemic stroke now involving the gangliocapsular location again. But this is a very small volume stroke. So such a small volume stroke, definition wise, any stroke less than 15 mm in diameter, particularly involving the basal ganglia, is called as lacunar stroke. This lacunar stroke affects the same. Remember the Charcot's artery? So your lenticulostriate branches, your lenticulostriate branches of the MCA, now instead of bleeding, what they're going to do is they're going to get blocked. That is what is called as lipohyalinosis. So lipohyalinosis is what happens. These arteries become narrow and they develop the small volume stroke of the basal ganglia called as lacunar stroke. So this is what we need to know about these images related to stroke. Now talking about brain tumors, so I'm going to show you 6 tumors, 3 in adults, 3 in children. You need to know the pattern approach in order to distinguish them. So look at the first one. This is the most common benign brain tumor in adults. What is the feature? The hallmark of this lesion, it's a very vascular tumor which has this tail. So you can see that there is a tail which is involving the dura. So dural thickening with a dural tail sign. This is what is diagnostic of a meningioma. So this is a meningioma dural tail sign. This one here is the most common malignant tumor of adults. It's a WHO grade 4 tumor, the most aggressive tumor. You can see how necrotic it is. The periphery is enhancing, center is not enhancing, and the classical feature is it is crossing the midline. There are very few things which can destroy the corpus callosum and go to the other side, and this is one of them. So this is what, because of its midline crossing ability, is been referred to as a butterfly glioma, and the diagnosis becomes GBM, glioblastoma multiforme, now called as glioblastoma. Okay, so this is the most common malignant tumor. The next one, the location is the hallmark. You can see this is the pons and these are the cerebellar hemispheres. So this is located at the CP angle. So this is the most common CP angle tumor. CP angle meaning cerebellopontine angle. Here you can see this classic appearance of an ice cream cone. So this is the ice cream cone appearance, and what is the diagnosis? This is vestibular schwannoma. So this tumor arises from the vestibular nerve in the internal auditory canal, where it tapers, and then at the CP angle cistern, it expands, giving rise to this classical ice cream cone appearance. Which syndrome will you rule out when you see bilateral vestibular schwannoma or even a single one? This is associated with NF2, right? So neurofibromatosis 2, where the hallmark is vestibular schwannoma. Moving on to tumors in children now. So this one here is the most common benign tumor in children. It is located most commonly in the cerebellum, and this pattern here is a cyst with an enhancing mural nodule. So this tumor is a cystic lesion with an enhancing mural nodule, and what is the diagnosis? So the diagnosis becomes pilocytic astrocytoma. So this is a WHO grade 1 tumor, most common benign lesion, pilocytic astrocytoma. The next image, where is the tumor? We have already seen the normal anatomy. You can see that the diamond-shaped fourth ventricle is now replaced by this tumor here. So this is the most common malignant brain tumor in a child. This occupies the fourth ventricle, and this is medulloblastoma. So medulloblastoma is in the fourth ventricle. It's a very aggressive tumor, and because of its location, this has access to the spinal canal. So what happens is the tumor drops, right? The tumor drops down and can coat the entire spinal cord, and that is what we call as drop metastasis. So this can lead to drop metastasis, and very important, because of its high propensity to cause spinal metastasis, brain metastasis. This is one of the indications of giving prophylactic craniospinal irradiation. So one additional point for all of you, prophylactic, meaning even though there are no metastases yet, there are few tumors which have such high propensity to cause brain and spinal cord metastasis that upon diagnosis itself, you're going to give prophylactic craniospinal irradiation. What are those tumors? So the first example is medulloblastoma that we have seen. The second example is small cell CA lung. Small cell CA lung tends to have high propensity of invasion. It's a very, very aggressive tumor with most common aggressive hematogenous metastasis. And we have ALL. ALL also tends to have craniospinal metastasis. So actually everything is there in the word small. If you just remember small, you are sorted. So one is small cell CA lung, M for medulloblastoma, ALL for ALL. Yeah. So if you remember small, everything is done here. Third one, and the most important one, perhaps most commonly asked lesion, whenever you see a child. So first C here is a child with a suprasellar lesion above the cella, which is calcified, It's actually cystic. It is filled with this keratin here that we describe as wet keratin. It has been described as machine oil on gross specimen. So cystic lesion with calcification, because it is suprasellar, this can compress the optic chiasma, leading to bitemporal hemianopia. So all C's together, the diagnosis is craniopharyngioma. So whenever you see the C, all of it goes together, right? So these are 6 tumors that we need to remember in total, 3 in adults, 3 in children. 4 patterns we need to understand as far as infections are concerned. So look at the first MRI. What do we see? Before I go into that, what did we understand as a concept? That whenever we have infection, tumor, inflammation, what will be my investigation of choice? It will always be MRI, and we shall always give contrast. So it is contrast enhanced MRI, whether it is tumor or it is infection, right? So I assume you will not have to memorize these things. These have well been understood as we have done the thumb rules earlier, right? So I've given contrast, and look at the first MRI here. You can see that there is a lesion which shows me enhancement in the periphery. So what is this ring enhancing lesion? So whenever you see such a ring enhancing lesion, this is what is a cerebral abscess. So this is a brain abscess. If we do a diffusion weighted imaging, we remember this can show us diffusion restriction because of the pus in the central part. This will show restricted diffusion. So this is a ring enhancing lesion, which is an abscess. What part of the brain? So you know these are the frontal lobes, these are occipital lobes. This is a temporal abscess here. Alright, so this is how an abscess appears, as a big ring enhancing lesion. If you have small ring enhancing lesions, now there are 2 considerations. One is NCC. NCC meaning neurocysticercosis, and the second consideration is TB. So what I'm about to teach you is how to distinguish these lesions. This image here is a T2 weighted MRI. We can see these multifocal lesions. It may be single also, it may be multifocal also. So don't always look for multiple. That's one mistake I've seen students do, is if it's a single cysticercus lesion, they will not make the diagnosis. They'll be like, no ma'am, but we have learned starry sky. But you don't always you'll not always see a starry sky appearance. It can be a single lesion as well. So what you have to understand is, starry sky hai, then it's good. But if it's not there, doesn't mean you rule out the diagnosis of NCC. Yeah. So what is the hallmark is that there is going to be a lesion which is cystic, and this dot here is the hallmark which represents the central scolex. So when you have either a T2 weighted image or they give contrast enhanced image with a central eccentric dot, that is a scolex, and that represents the diagnosis of neurocysticercosis. This is caused by Taenia solium. You know the intermediate host is pig, but this is not necessarily because of eating pork. This can also be consumed with unwashed vegetables. So actually the eggs of the Taenia solium come with the vegetables. So if you are eating, unhygienic vegetables, salads, momos, those are the usual carriers of neurocysticercosis. On the other hand, in tuberculomas, you can see these multiple ring enhancing lesions. Again, a property that you see here is that these lesions are conglomerating, meaning they are merging into one another. That's the first point. The second point, which is an old repeat AIIMS question, is if you do MR spectroscopy, you're going to see a lipid lactate peak. This just indicates the presence of necrosis basically. So these are your 2 or 3 differentiators. Scolex means NCC. Conglomerating or lipid lactate peak means tuberculosis, right? The fourth infection, where the buzzword is now going to be HIV AIDS. So if I tell you there is a patient who is HIV AIDS positive, and again I'm seeing these target shaped lesions. You can see there is ring enhancement with a central target, but this is not like NCC. This is involving the basal ganglia. Plus HIV AIDS will always be mentioned. This is toxoplasmosis. It's the most common infection in HIV/AIDS. So toxoplasmosis, you're going to make a diagnosis with HIV/AIDS in the history. Right? So these are the 4 patterns of infections we need to know. Talking about paranasal sinus x-rays, just the names, they've been asking this a lot. So what is this here? When you see the maxillary sinuses, right? This is the best x-ray for maxillary sinus. This is a modified Waters view. Why am I calling it modified Waters? This is also called as Pierce view. The modification is that now we do an open mouth. So this is an open mouth Waters, also called as modified Waters, also called as Pierce view, which is the best for visualizing maxillary sinus. So look at this. These are the maxillary sinuses. You can see that there is an air fluid level here indicating sinusitis, right maxillary sinusitis in this case. This is how normal sinuses will appear completely black. Okay. Another question which may be asked is how do you acquire this X-ray? So when we are actually having a straight face, right? If I'm just taking X-ray like this, the pterygoid plates are going to overlap the maxillary sinuses. So in order to free the maxillary sinus from the pterygoid plate, I'm going to have to pull up my chin. So what happens is, this is the image receptor. So what we do is we pull up the chin like this. So that way, the pterygoid plates are actually going to go down and the maxillary sinuses come up. So just to give a diagrammatic representation, not a great diagrammatic representation, but will do the job. This is the image receptor. Imagine this is the patient. Okay, so the angle between the chin and the image receptor is around 37 to 45 degrees. This is a repeat question, very weird repeat question. I mean, I don't know why they had to ask this, but the logic, I hope you understood. We have to lift the chin out so as to free the maxillary sinus from the bone. So this is how we acquire a Waters view. On the other hand, look at this X-ray. So normally when you keep your face straight, this is how the X-ray will result. Can you appreciate it? That I have bones over the maxillary sinus. This is what is done to view the frontal sinuses. So this view here is the Caldwell view, and Caldwell view is the best for frontal sinus. Now all of these X-rays are good questions for the exam, but in practice we don't really do these views anymore. You know, sometimes some centers do Waters, but that's it. The investigation of choice for paranasal sinuses is NCCT/high resolution CT. So remember, the best investigation is HRCT, that is done in practice to visualize paranasal sinus pathologies. So now let's have a look at the questions from here. So what is the management of choice for aneurysms performed by interventional radiologists? So as we said, we are going to be doing coiling. Don't get confused by clipping. Clipping is a surgical approach. So a surgeon can externally also clip the aneurysm. So this is what is done for very, very big aneurysms which have a broad neck, but the preferred method done by radiologists, endovascular, is coiling. Okay. Which of the following associated with banana sign on ultrasound? So banana sign is seen with spina bifida. So this is where, can you look at these antenatal ultrasounds? So this is where you can see the bifrontal constriction here. This is what is called as the lemon sign, and the cerebellum has this contour of a banana here. So lemon and banana sign are associated with Chiari malformations actually. So Chiari malformations also can be referred to as spina bifida. So that is where we see lemon and banana sign. Next, a 34-year-old woman landed up in AIIMS emergency after an RTA with a GCS of 3, minimum GCS. She was intubated. Any patient with a GCS less than 8 is an indication of intubation, which is that severe head trauma. And NCCT was found to be normal. At such a low GCS, when the NCCT is normal, what do we suspect? We suspect a diffuse axonal injury, right? Which of the following is most likely due to rupture of saccular aneurysm? We know it. It's an arachnoid hemorrhage. 10-year-old boy presented with seizure and fell unconscious. Imaging is done. What's the diagnosis? This is what a lot of students got wrong. They were like, ma'am, NCC you said should be starry sky, multiple. But what did we see here? We see that there is a lesion with a central eccentric scolex. So when you see this focus of calcification here, this is what is the hallmark telling us it is NCC. So when you have a single NCC, it can present with a focal seizure. When you have multiple NCC, it can present with generalized tonic-clonic seizures, right? So this is an NCC, and that is by this foci of calcification eccentrically. Next, what is the structure marked in the CT scan? So this was apparently, students found this to be a tough question, but let's see if you can eliminate, even if you can't really answer this prospectively. So this is a CT scan of the paranasal sinus. First of all, these are the maxillary sinuses, and you can see that there is this polypoidal thickening of the left maxillary sinus. These are the inferior turbinates. These are the middle turbinates. You can see that on the left side, the middle turbinate has some air. So pneumatized middle turbinate is called as concha bullosa. So this is a middle turbinate which has air in it, right? Now look at what they have pointed towards. First of all, what is cribriform plate? This central piece of bone that you see here is the crista galli, and the two thin plates of bone, the roof of the ethmoid sinus, are the cribriform plate. So this is the cribriform plate surrounding the crista galli. So what has been marked, it's clearly not the cribriform plate. Now my question to you is, are we anterior or are we posterior? You can see the complete orbit here. You can see the maxillary sinuses. All of these are anterior structures. If I go behind, I'm going to see the optic nerve, and that is where you will have the posterior ethmoidal canal. So both of these can also be ruled out, that it's not posterior, we are anterior. I'm not going to be seeing optic nerve here where you can see the globe, isn't it? So this is where you're seeing the globe. So I can't see the optic nerve at this point. So what is this? This indeed is anterior ethmoid canal. So nobody expects you to tell anterior ethmoid canal, but they just want you to rule out the others, right? So that's what you need to know in paranasal sinus. Apart from this, I've also taught you about ethmoidal air cells. In ENT, BTR, we have discussed that, but still just to confirm, on the medial aspect of the orbit is the largest ethmoidal air cell, which is bulla ethmoidalis. Infraorbital, which can be a variant which may or may not be present, is the Haller cell. Posterior ethmoidal air cell, which is in association with optic nerve, is the Onodi cell. So these are the cells you want to know about: Haller, bulla ethmoidalis, and Onodi, right? Next, what is this investigation here? So you can see there is contrast within the spinal canal. This is called as myelography. This was done previously when we didn't have MRI. So they would put contrast in the spinal canal if there is a tumor that will cause some filling defect. Obviously, this is not MCU. If you know what MCU is, this is nowhere close to bladder. What is vertebroplasty and vesselplasty? So vertebroplasty and vesselplasty are where you inject bone cement in the vertebra. Vertebroplasty is plainly injecting the bone cement, whereas vesseloplasty is where you're going to put this balloon sort of a structure and then you're going to put cement inside it. Both of these are used for vertebral fractures, compression fractures. We used it to strengthen the vertebra. So this is a myelography. 2-month-old infant brought to the OPD with a parietal swelling since birth. X-ray was ordered and is shown below. What is it? This is where a lot of students get confused. First of all, this is a lesion where you can see this thin rim of calcification. As soon as you see this, it cannot be caput succedaneum. Caput is just edema. It resolves in a day or two. In 1 to 2 days, it resolves. Can't be caput. It can't be encephalocele. Encephalocele is brain herniation. It will not be a well-defined lesion. Cephal hematoma versus subgaleal hematoma. Subgaleal hematoma is diffuse. It can be a complete scalp swelling. Nothing can stop a subgaleal hematoma. So it can go and have the entire scalp involved. So that's why it will not be a focal swelling. It will be a diffuse swelling. Cephal hematoma fits everything. It is a focal swelling. The hematoma resolves to form this small calcified swelling here. So the answer is cephal hematoma. Identify the mark structure. A lot of students mark this incorrectly, but look at the density. Is it basal ganglia or is it internal capsule? So you can see this is darker. What is darker is white matter here. So you can see this is the thalamus, this is the lentiform nucleus, this is the caudate, and what has been marked where the arrow exactly is the internal capsule, and lateral to it lies the external capsule. So this is the internal capsule here. Next, chronic ear discharge, headache, ear pain. There is an abscess. Where is the abscess? So again, you can see this is the pons, cerebellum, temporal, frontal. So this is a temporal abscess, right? So if it was here, it would have been a frontal abscess. If it was here, cerebellar abscess. Next, 10-year-old child presents to the ED with vision loss in bilateral temporal fields. Means we localize it to the optic chiasma. Optic chiasma meaning bitemporal hemianopia, right? So child, and look at the CT. You can see that there is a cystic lesion with calcification. These white foci are calcifications. What is it? C for craniopharyngioma. Pituitary adenoma is seen in adults. It's a solid enhancing lesion, not a cystic lesion with calcification. Rathke cleft cyst is usually very small, intracellular. It will not expand to block the optic chiasma. And meningioma will see a dural tail. We don't see any of it. With this, we complete neurorad. Now we go on to musculoskeletal radiology. A lot of overlap with what you'll study in orthopedics also. So if you've done ortho already, it'll be like a revision. If not, I would advise you to do ortho immediately after this. So that will be a revision. Okay. So before I go into anything, I just want to brush up on the thumb rules here because that's important. Now, anything to do with bone cortex, right? So your fractures, osteoid osteoma, which was a cortical based lesion, you know, we will rely on CT. But when we talk about the bone marrow, when we talk about bone marrow, when we talk about cartilage, when you want to see ligaments, when you want to see soft tissue, then my reliance is on MRI. So this is what is the basic concept of imaging in MSK radiology. With this background, we start with bone tumors. In bone tumors, first off, you now have understood that investigation of choice for bone tumors is MRI because we want to see the bone marrow involvement, but you won't be shown the MRI. What you need to know is on the X-ray, how do I make a diagnosis? For that, where you always never jump to diagnosis, you always start off with the location. That's the first step you have to follow. You will see whether it is epiphyseal, metaphyseal, diaphyseal. What does that mean? If this is the bone, if it is attached to the joint surface, it is epiphyseal. In between is metaphysis, shaft of the bone is diaphysis. So the first step is to see this. If it is epiphysis reaching the joint, that is epiphyseal tumor. You have to consider 2 DDs. Remember ECG. So if it is a child, C for child, C for chondroblastoma. So if you see an epiphyseal tumor reaching the joint surface in a child, even if they don't give me this as a child, I can see that the growth plate is not fused here. So this has to be a child. This is a chondroblastoma. On the other hand, if they give me an adult patient here who is around 30 to 40 years of age, and you can see it is reaching the joint surface, the other feature here is the soap bubble matrix This is what is a giant cell tumor. Perhaps the most commonly asked question in the history of entrance exams is this. Don't get this wrong. If you see 30 to 40-year-old patient with an expansile lesion, epiphyseal lesion with a soap bubble matrix, this is giant cell tumor. The other name of giant cell tumor is osteoclastoma. So the osteoclasts are the giant cells of the bone. So this is osteoclastoma. Is this clear? So remember, ECG, epiphyseal is chondroblastoma or giant cell. Age will do the job for you, right? Moving on to diaphyseal tumor. You know how in BTR you would have studied vowels stick together. That's what I keep saying. All three vowels are diaphyseal tumors. So the first one is where they'll give you the history that there's a patient who has nocturnal pain that is relieved on taking NSAIDs. Why so? That is because in these tumors, you have a nidus that leads to formation of prostaglandin E2. You can remember pain, you'll do E. So E is PGE2. Because NSAIDs will block the production of PGE2, you have pain relief on giving NSAIDs. So the diagnosis becomes osteoid osteoma. So this is what you need to remember. Osteoid osteoma has a nidus. So this is a very tiny lesion. On an X-ray, you will just see some bit of cortical thickening here. On the CT, remember we said this is cortical based, and that is why this is the only one where investigation of choice is actually a CT scan. So on the CT, you can see there is thickening of the cortex, and sitting in the cortex is this small nidus here. The gray part is the nidus which releases the prostaglandins. So this is osteoid osteoma for you. Unique diagnosis, unique treatment. Now, this is a benign lesion, right? Osteoid osteoma. It is not gonna do any harm to you except for the pain. So can I just burn the nidus and not remove the lesion? Yes. So that is why the treatment here is radio frequency ablation. All you do is ablate the nidus. So that is what you need to know from osteoid osteoma. Look at this diaphyseal lesion, huge mass. So they'll give you that there is a child here, a child in the first or second decade having a huge mass. You can also see that the periosteum is interrupted. Another misconception students have is that whenever you see onion peel, only then will it be Ewing sarcoma. When you see such a triangle, it is osteosarcoma. Not really. Codman's triangle, onion peel, all of these just represent aggressive tumors. They are periosteal reactions representing aggressive growth. So it's not necessary that every time you are going to see the onion peel, every time Codman triangle is osteosarcoma. No, both of them just tell me it's a malignant lesion. So here you can see this incomplete periosteal lifting indicating a very aggressive lesion. So an aggressive lesion in the diaphysis of a child is Ewing sarcoma. So this is Ewing sarcoma for you. This is the most radio sensitive tumor. This is also the most chemo-sensitive tumor. So basically the management is going to be a combination of chemo plus radiotherapy. So this is Ewing's sarcoma. In PATH, we also study translocation 1122 with this. You know the markers are CD99, MIC2. You need mnemonic. You can remember 11 2s are 22. 11 table is 99. So that's how we can remember all of these features. The third diaphyseal tumor is pathognomically seen in the tibia here. So tibia with associated bowing. There may be anterolateral bowing of the tibia in a lot of cases. This is adamantinoma. So this is adamantinoma seen in tibia. So diaphyseal tumors, as I said, 3 vowels stick together. Right? So this is about diaphysis. Talking about metaphyseal tumors, so look at this lesion here. You can see, first of all, the epicenter is in metaphysis. right? You can see white colored matrix because this is a bone forming tumor. You can see how there is this sunburst reaction. You have spicules which are going parallel along the blood vessels. So this is the sunburst periosteal reaction. You can see how the periosteum is lifted off like this to make this Codman's triangle. So what is the diagnosis? This is osteosarcoma. So osteosarcoma, you will see sunburst periosteal reaction, Codman's triangle. This is osteosarcoma. Most common malignant primary bone tumor here. This is the most radio-resistant bone tumor. So this is the most common radio-resistant bone tumor, right? So this is osteosarcoma. Two cysts that you can see here. Here you can see, first of all, in both of these that they are metaphyseal. The growth plate is not yet fused. Look at this lesion. You don't see any matrix here. So this is what is a simple bone cyst, SBC, simple bone cyst, also called as a unicameral bone cyst. So SBC or UBC may be mentioned here. And what you can also see associated with it is a fracture. A fracture in the setting of a bone tumor is what we call as a pathological fracture. So this is a pathological fracture, and you can see the fracture fragment is actually floating here, which is called as the fallen leaf sign, also called as the trapdoor sign. So trapdoor sign, fallen leaf sign seen in simple bone cyst. On the other hand, when you see that there is this soap bubble appearance that we saw in GCT, very similar to it, but then this is metaphyseal. Lots of students confuse GCT with ABC. GCT, you will see in epiphysis, reaching the joint, whereas this is unfused. This is in meta. This is the epiphysis here, right? So this is a metaphyseal lesion. This is the aneurysmal bone cyst. So ABC, aneurysmal bone cyst, is metaphyseal. Three more tumors, very, very important. When you see a tumor growing out of the bone like a mushroom here, this is what is called as exostosis or osteochondroma. The name itself tells you that there are two components to it. One is the bony component that you can see on the X-ray, and the other is the cartilage. The cartilage is something, as we saw, is not detected on X-ray or CT. We need MRI to see cartilage. So look at the MRI here. Can you see how, like a mushroom, there is a bone tumor growing out, and then we can see the cartilage cap. But you'll be like, ma'am, I could already make the diagnosis on the X-ray. Why did we have to see the cartilage cap? The cartilage cap is very, very important because these tumors have a risk of developing chondrosarcoma. So they tend to become chondrosarcoma, and for that we need to monitor the thickness of the cartilage cap. So what we do is we measure the maximum thickness here. The moment this thickness becomes more than 1.5, some people also use 2 centimeters, whatever is given you can accept. So more than 1.5 centimeter, what you have to do, you need to remove it. So we keep monitoring these patients on MRI. If the cap is more than 1.5 centimeter, that is an indication of surgically removing this osteochondroma. Whenever you see the hand of a patient, hand, you remember AN, make it EN. So this becomes enchondroma. So this is enchondroma. Usually you will see multiple enchondromas in the multiple short bones of the hand. This syndrome, when you see multiple enchondromas, is called as Ollier's syndrome. If they give you, the patient also has blue lesions, skin lesions, which are hemangiomas in addition to enchondroma, the syndrome becomes Maffucci syndrome. So we have Ollier's syndrome and we have Maffucci syndrome in addition when we have hemangiomas. Look at this X-ray here. You can see that within the metaphysis of femur, there is a lesion which has this ground glass matrix. We have seen ground glass in COVID. This is ground glass of the bone. And whenever you hear ground glass, you have to think of fibrous dysplasia. This fibrous dysplasia can cause the femur to be twisted as such, and this is what is called as the Shepherd Crook deformity. Apart from this, you want to remember, if they give you that the patient also has endocrinopathies, precocious puberty, the syndrome that is associated is McCune-Albright syndrome. So McCune-Albright syndrome, Shefford-Crook, ground glass, all of these are your buzzwords for fibrous dysplasia. One more tumor here where they'll show you the flat bones getting involved, and this huge tumor here having this sort of a stippled calcification, also called as ring and arc popcorn calcification. So when you have this is what is indicative of chondroid matrix. So this is chondrosarcoma, malignant tumor that frequently affects the flat bones like the pelvis, chest wall. Those are the usual sites of a chondrosarcoma. This is the classic matrix of a chondrosarcoma. Now we are going to be seeing a bunch of spine x-rays and understand how to differentiate them. So these are the two images that we need to do here. So the first spine, you can see that there is this alternating white and black pattern that you are seeing. So this is what is called as the Rugger-Jersey spine. So this Rugger-Jersey spine, these alternating sclerotic and lytic bands are what you see in secondary hyperparathyroidism. So this is a feature of secondary hyperparathyroidism, also called as renal osteodystrophy. Why and how and what are the metabolic changes? I've taught you in renal system of BTR. So that is what is CKD related spine changes, Rugger-Jersey spine. When you see that there is this white bone here, like ivory, right? So this is what is called as ivory vertebra. Independently, this can be seen in many conditions. 1DD is Paget's disease. You know how in Paget's you have blastic phase, lytic phase, mixed phase. In the blastic phase, you will see this ivory white appearance. This can also be seen in Hodgkin's lymphoma. So Hodgkin's lymphoma is another DD. And very, very important is there can be blastic metastasis. Two primaries which give rise to blastic metastasis. One is breast CA in women and prostate CA in men. Both of these are causes of blastic metastasis, and something linking both of these. The spread of metastasis to the spine is also common. Both of them spread via the epidural venous plexus, which is called as the Bateson's plexus. So both of them reach the spine via the Bateson's venous plexus. So this is what you need to know about white ivory vertebrae. Three differentials: Paget's, Hodgkin's lymphoma, blastic metastasis. Look at the third spine X-ray. What can you see? You can see that the density of the bone is gone. The bone is not even looking white. It's looking completely black. And because the bone is so weak, look at how bent the bones are. It is looking like a codfish mouth. So this codfish mouth appearance is what you see in osteoporosis. Osteoporosis is a generalized reduction of bone mineral density. The metabolic levels, calcium, phosphate, PTH, ALP are all normal here, right? So that is what is very, very important, that this is a generalized reduction of bone mineral density as the age of the patient increases. So frequently they'll give you that this is a post-menopausal female here. So this is osteoporosis. Remember, the investigation of choice is a DEXA scan. DEXA scan, you know, stands for dual energy X-ray absorptiometry. So what we do is, I take the bone mineral density of our patient and we compare it with a young adult's density. Young adults wear t-shirts, isn't it? So that gives us a T-score. So when I compare the density of my patient with a young adult's bone mineral density, we get a T-score. Any T-score below minus 2.5 standard deviation is what is the definition of osteoporosis. So this is the definition you need to keep in mind. Next case, you can see that there is a young male here. They'll tell you the patient has inflammatory backache. The moment you hear young male, look at the spine. The spine is completely fused. It's looking as if it's a bamboo spine. It's a fused bamboo spine. You can see the spine getting completely fused. You can see here the interspinous ligament is ossified. What is the diagnosis? This is ankylosing spondylitis. So remember, ankylosing, you can just remember ankspond. Ankylosis means to fuse. Spondylitis is inflammation. So this actually starts off with sacroiliitis. So the earliest finding here, remember, is actually sacroiliitis. This sacroiliitis can be picked up on an MRI. So the investigation of choice, or the most sensitive investigation of choice, is MRI, and then it involves the spine, where the spine becomes completely fused. HLA B27, as you know, is associated. Various named signs fused like a bamboo. You can see a tram track appearance. This interspinous ligament ossification is what is called as a dagger sign. So these are the various signs which are associated. You can also be given history of uveitis, red eyes in the patient, bilateral heel pain. Bilateral heel pain is because of associated enthesitis. What is enthesitis? Wherever you have attachment of tendon and ligament, that site becomes inflamed. For example, if this is the calcaneum, the point where the Achilles tendon has to insert, it becomes inflamed. Looking at the next image, so you can see here in the spine that there is a lateral curvature which is associated. So this lateral curvature of the spine is what we call as scoliosis. They frequently ask you what is the angle that is being measured here. So this is what we call as the Cobb's angle. So this is the Cobb's angle, which tells us about the severity of scoliosis. Two more spine x-rays. So here, if I give you a hint that this patient has black discoloration of pinna, sclera, what is that? That is called as ochronosis. So ochronosis is basically calcification of the cartilage, blackish discoloration, and that's the radiological finding which has been tested here. You will see that the intervertebral discs here are calcified. People frequently confuse it with Angstpon. There's nothing to do with Angstpon. What you see here is the calcification of the intervertebral disc, right? So that's ochronosis. On the other hand, if you see such a spine appearance where there is this flowing ossification along the anterior longitudinal ligament. So ALL is the ligament connecting the anterior part of vertebral bodies. When you see that there is this new bone formation along it in an old patient more than 50 years, this is what we call as DISH. DISH stands for diffuse idiopathic skeletal hyperostosis. So essentially the only useful word here is hyperostosis. There is new bone formation like a flowing candle wax along the anterior longitudinal ligament in an old person is DISH. This is also called as Forestier's disease, right? So this is what we need to know. Now a pattern approach to this. When they give you a 5-year-old boy, low socioeconomic status, low bone density. So two causes of low bone density are rickets and scurvy. Both of them have different problems. In both, ultimately the bone is not forming, but in the rickets, the problem is you don't have calcium. There is no vitamin D. Because there is no vitamin D, or low vitamin D, there is low calcium. So how this presents is a deficiency of calcification at the growth plate. So what happens at the growth plate? You're going to have your chondrocytes which are waiting. This is the zone of provisional calcification. That is where calcium was supposed to come. It's not there. So now all of my chondrocytes are waiting, creating pressure on the metaphysis. That's why the metaphysis becomes cupped, splayed and frayed. There is cupping, splaying means separation, fraying means irregularity. So that is what you see in rickets. Because the calcification is not there, we have something called as zone of provisional calcification that remains deficient. And because of that, the resultant changes are going to be what you see at the metaphysis, namely metaphysis becomes cupping. There is cupping of metaphysis, there is splaying, and there is fraying. So these are the changes that we see. Once you give calcium in healing rickets, now what happens? The white calcification begins and you may see a white metaphyseal line. But don't confuse this with the white line of Frankel that you see in scurvy. How not to confuse? Both are white line, but in rickets, the irregularity is going to persist. So the white irregular line is what is seen in healing rickets, right? So that is what is the sign of healing rickets. But in scurvy, when we talk about scurvy, we also have a smooth metaphyseal line. The smooth metaphyseal line is what we call as Frankel's line. So this white line of Frankel with a smooth metaphysis is the hallmark of scurvy. In addition, what you see here is a Wimberger ring sign. So this Wimberger's ring sign is a very, very well delineated epiphysis that you tend to see here. Alright, so in scurvy, what is the problem? You know, there is lack of vitamin C, because of which the hydroxylation of lysine and proline doesn't happen. That is what vitamin C is a cofactor for. Because of absence of hydroxylysine and proline, you don't have collagen. So now calcium is there, the osteoid matrix is not there. You know, collagen 1 forms bone, 1 is bone. We have studied that in biochemistry, BTR. So basically, I don't have collagen. So because of that, now again, the bone density is going to be weak. Essentially, I don't have bone. So these are the few signs. There are few other signs as well. You see this spur here or the bony outgrowth, which is called as the Pelkin spur, or this lucent zone here that is called as Trummerfield zone. Don't memorize these names, not important. Just have this background. We're gonna look for this white line. Now, if I tell you another boy with short stature, but now the bone density is normal, what you see is that the metaphyses are again irregular and they have this V-shaped. Another finding you can see is that the femur is almost as long as the tibia, meaning the femur is shorter than it should be. So this is what we call as rhizomelic shortening. So this rhizomelic shortening is where you have proximal narrowing, right? So there is proximal shortening which is noted, and this metaphyseal irregularity is what is the characteristic feature of achondroplasia. Instead of achondroplasia, they may also write it as metaphyseal dysplasia. So achondroplasia, metaphyseal dysplasia is irregular metaphysis with a normal bone density, and this sign is called as chevron sign. So this is the chevron sign here. So this is our approach to bone disorders, MSK radiology in general. Let's look at the questions. This was a rather unusual question that was asked in the last INICET exam. I mean, we can never diagnose a patellar fracture on an AP view, and that is what they gave in hindsight if you want to look at it. So this is a patella and you can see that there is a fracture line here. So I don't know why and how this question has come. So this is patella fracture. Normally for patella, we will do what is called as a skyline view. This is what it will look like. This is not what it will look like, but basically you will see patella in view and there will be a fracture associated, okay? So that is how patella fracture appears. Next, a 5-year-old boy with inability to pronate and supinate. What you can see in the X-ray is a fusion of the ulna and the radius. You can see both of them have fused. This is an old FMG repeat question. This is radio-ulnar synostosis. Even if you have no idea what it is, just read the name. Ostosis means bone, syn means to fuse. There is no fracture that you can see here. There's no dislocation, right? So you can just rule out and reach the answer. 35-year-old male, pain, swelling, 35-year-old, epiphyseal, soap bubble. Please don't get this wrong. This is giant cell tumor. What is this here? You can see that this is the psoas muscle. There are these T2 hyperintense collections in the right psoas. This is what represents psoas abscess. So this is psoas abscess MRI. All of the following are useful in osteoporosis. DEXA is the investigation of choice. Bone scan has no role in osteoporosis, and we'll talk about bone scan in a few minutes. Chemical analysis is useful because we will find that all of the values are normal and it helps to rule out other metabolic bone diseases. Quantitative CT is a new investigation, not just quantitative CT, we are also now doing quantitative ultrasound. These are new investigations which are going to replace DEXA in the future because it gives you a full 3D volumetric bone mineral density. You don't really have to compare it with anybody. You can get an objective assessment. So these are 3 investigations that are used. So bone scan has no role in osteoporosis. Next image, there is a 40-year-old male with progressive forward bending and stiffness. What do you see? You see that the complete spine is fused. Here, there is this complete fusion instead of the X-ray we are used to seeing. Showing you the CT scan where you can see fusion. Look at this posterior elements being fused and there is increased density. This is Angst-Pond. Rheumatoid arthritis, remember, will involve the atlantoaxial joint, leads to atlantoaxial dislocation, doesn't involve the diffuse spine. Fluorosis will just have increased bone density of all the bones. A hallmark of fluorosis is the interosseous membrane, syndesmosis. So the interosseous membrane ossification is the hallmark of fluorosis. You are not going to be seeing fusion. Rita syndrome is a seronegative Angst-Pond. Basically, it's just like ankylosing spondylitis, but it involves peripheral joints more. It's a triad. We've learned this. Can't see, can't pee, can't climb a tree. Can't see meaning conjunctivitis, can't pee, urethritis, can't climb a tree, arthritis. So this is the triad of Rita syndrome. 70-year-old male, presents with history of painful limb, no drug intake, no trauma. What is the diagnosis? So here you can see that at the hip joint there is irregularity. You can see this sclerosis and flattening of the femoral head, and you can see some lucency inside. So when you see femoral head sclerosis with this lucency, this is what is called as the crescent sign, and this is diagnostic of avascular necrosis. Usually AVN will have history of steroids or will have history of trauma. It's a bit weird that they have ruled that out, but it may be seen independent of that as well. But just telling you the risk factors for AVN. TB hip should have some sort of joint involvement. There should be some joint destruction there, which is not seen here. Angst-Pond, this is not Angst-Pond. Angst-Pond will have fusion of the SI joint. RA, rheumatoid arthritis, will have erosions. Again, it is an arthritis, so the joint should be affected. Here, it's not the joint, but the femoral head which is affected. So that's what is the primary diagnostic criteria. Marked ligament, we studied this in ortho-BTR. This is what is the cruciate ligament. Now, cruciate ligament means it crosses. So, when something crosses across the joint, it's cruciate. Is it ACL? Is it PCL? The naming is on the basis of where on tibia do they insert. If it inserts posteriorly on the tibia, it's PCL. If it inserts anteriorly on the tibia, it's ACL. So in this case, it becomes the posterior cruciate ligament. The menisci are going to be in between. They don't cross, and collateral, they will never ask you. They're very thin ligaments and it's seen in a coronal plane. Even radiologists have trouble finding it, so they're not going to ask you. So either it's cruciate or it's menisci that you have to remember. Moving on now to radiotherapy and nuclear medicine, the last miscellaneous part that we have to cover. They are general theory questions. You may get 1 or 2 questions from this, and they're usually straight one-liners. You can't afford to go wrong here. This has not been asked in a lot of years. If it does get asked, it's something you may not know otherwise. So that's why I'm teaching this. So what are the effects of radiation? Why do we say radiation is bad? So there are 2 kinds of effects you have to remember, stochastic and deterministic. The word stochastic means literally by chance. So these are not going to happen in everybody. It depends on chance. So there is no threshold. There is no threshold beyond which I will say that this patient will have this effect. It is a delayed effect. The classic example being cancer and mutations. So there is no threshold beyond which mutations start or cancer risk increases. So this is what you need to remember, that stochastic effects happen by chance, and these are all or none effects. Either you have a mutation or you don't have. You don't have a little bit of cancer. Yeah. So these are by chance. On the other hand, deterministic effects have a threshold that if you cross this threshold, you will get erythema, you will get cataract, you will get hair loss, which is epilation. And these happen immediately. As soon as you get radiation exposure, these will happen. So this is the difference between the two. Now talking about radiation units. So this is where you need to remember SI units as well as conventional units. First, let's talk about radioactivity. Radioactivity, the SI unit here is becquerel. So becquerel, the father of radioactivity, is SI unit. C for conventional, C for Curie. Curie is the conventional unit. The relation, no need to remember, but 1 Curie is 3.7 into 10 raised to 10 becquerels. Forget it. Coming on to others. Now we are talking about radiation per se. Suppose this is the radiation source. How much is the radiation that it is giving in the environment is the exposure. The SI unit is coulomb per kg. How much charge per unit mass? That is the SI unit. Now the trick to remember, one was C is C. Now all of the other conventional units are going to be starting with R. So that's the first trick. So here, who is the conventional unit? It's none other than the father of radiology, who is Röntgen. Why Röntgen is father of radiology? Because he discovered X-rays, right? You must have seen the hand of his wife. So this was accidental exposure. He was doing some work and he found that, oh, it's a picture of my wife's hand. And that is how it led to the discovery. At the time, they didn't know what is going on. So that's why they called it X-rays, for which he was given the Nobel Prize in 1905. So, Röntgen, the relation between the two, no need to remember. 1 Röntgen is 2.5 into 10 raised to minus 4 coulomb per kg. Absorbed dose and air karma have the same unit. For that, you can remember ABG rad. What is ABG rad? You know how we integrate stuff. So, we integrate ABG with radiology. So, absorbed dose, SI unit is gray, R is conventional. So, that's rad. So, gray and rad. 1 gray is 100 rad. Equivalent effective dose thankfully have the same unit. SI is starting with SI. So that is sievert is the SI unit and rem is the conventional unit. So 1 sievert is 100 rem. Equivalent dose basically is for different radiations. For example, I have alpha rays which have maximum damaging power. Then I have gamma rays which have minimum damaging power. So how can I equalize them with the same unit? That is the equivalent dose. It takes into account the different radiations. Effective dose takes into account the different tissue sensitivity. For example, thyroid will have a different sensitivity as compared to the bone. So that tissue sensitivity is taken into account in effective dose. So if they ask me what is the most useful expression of radiation unit, that becomes effective dose. So this is what I need to know from radiation units. Now let's talk about maximum permissible dose. So this is how much dose are we allowed as radiologists and as public exposure. And here I am not talking about investigations per se. I'm talking about the background radiation that we face. So if you are a patient, then these limits don't apply obviously. If you are undergoing a CT scan for some diagnosis, it doesn't apply. But what is the radiation that the background radiation constitutes? So overall, for anybody working in radiology, it is 20 millisievert if you average it out over 5 years, but for a single calendar year, it is 30 millisievert. So 30 is a better answer. Whatever is there in the option, you mark. For public, aam janta, aam number, 1 millisievert per year. Lens is the most radiosensitive part. So that's 150. For public, remove a 0. Skin extremities, it's 500. Remove a 0 for public, becomes 50. This is what is very, very important. How much is the allowed radiation dose for a pregnant occupational worker? That is 2. You can remember 20 and then take out a 0, it becomes 2. Whereas for normal, it's normal. Any pregnant female is normal public. So that's 1 millisievert. Fetus, imagine half the radiation of the mother is shared by fetus. So that is half and half. So 2 divided by 1, 1 divided by 2. So don't remember both. Essentially, the takeaway here is 1 millisievert, 20 to 30 and 2 millisievert, and you are sorted. 2 images that can be tested. So what is this here? This is what we call as a TLD badge. TLD badge is the badge used for personal dosimetry. So this is what measures the radiation to occupational worker. This is thermoluminescent dosimeter. So thermoluminescence is the principle. The compound that is used to make it is calcium sulfate, which is having this dysprosium compound in addition. That is what is used in India. Apart from this, even lithium fluoride can be used, but the former is cheaper and that's why we prefer that. So this is thermoluminescent dosimeter. A radiologist is going to wear it, and every 3 monthly, this is what is submitted for reading. So in the last 3 months, how much is the exposure that I've had is measured by the TLD. So every 3 monthly, we have to submit it and the dose is calculated, right? Where do I wear this badge? So we're going to wear it near the collar pocket, above the lead apron or below the lead apron. So this is the lead apron that protects me by absorbing the radiation. So where should I wear it? So obviously we want to know how much I am getting, not how much apron is getting. So I'm going to wear it below the lead apron at the chest level. So that is the first thing. The thickness of lead apron, they asked. The most common thickness is 0.5 millimeters, whereas the minimum thickness of a lead apron is 0.25. Both have been asked. So most commonly 0.5, minimum thickness 0.25 mm. Now let's venture into, so this was all general radio that we had to do. Now we venture into nuclear medicine. So first of all, I want to tell you the concept of nuclear medicine. We have these technetium-99m studies. So these are technetium-99m scintigraphy studies. For example, I want to know about parathyroid adenoma. What I do is I link this technetium-99 with a compound called Sestamib. This Sestamib has a property to go to parathyroid adenoma, if any. My technetium has been clubbed with it. So technetium also tags along. Wherever there is parathyroid adenoma, both of these guys are going to bind to it, and the technetium is then going to emit gamma rays. So that is what my gamma camera will detect. If there are gamma rays being emitted here, they will be detected as this hotspot. So such a study is called a scintigraphy study. Same thing, I give technetium Sestamib and now I do a CT scan instead of gamma camera. There are both. There is a gamma camera with a CT scan. Now I can get a 3D localization, isn't it? I'm also seeing a CT in the background along with that hotspot. So now I know the exact site of where this parathyroid adenoma is. Such a study is called a SPECT study. What is a SPECT study? It stands for single photon. Photon is the word you need to remember. Single photon emission computed tomography. So this is where I've combined my technetium study with a CT scan, and that gives me the exact 3D localization of the parathyroid adenoma. So if I ask you, is a technetium Sestamib scan better or a technetium Sestamib SPECT better? You'll be like, ma'am, obviously you're giving me a CT in addition, so it's SPECT. So this is what was tested in INICT, right? So if SPECT is there, mark SPECT. If SPECT is not there, just technetium Sestamib. So these are a few nuclear medicine scans that you need to know about, and I'll tell you the applications of each. So technetium-99 MDP. Everywhere we have the same technetium because that's my gamma emitter, and then I tag it with a compound which will take it to the target organ. So I hope you got the concept. So technetium MDP is what we use for bone scans. Look at the image first. So this is how a normal bone scan will appear, wherein there is no particular hotspot. All of the bones are diffusely symmetrically taking the compound, and you can see it's getting excreted from the kidneys into the bladder. Now, if there is any area where there is abnormal bony turnover happening, for example, metastasis or a primary bone tumor, you will see these hotspots. So this is where you can see these multifocal bony metastases presenting as hotspots on bone scan. So that is how bone scan is going to pick up multifocal metastasis. So hotspots will be seen in mets, it will be seen in bone tumor, essentially anywhere bone turnover is happening, like a fracture, like a metabolic bone disease, right? But what is very important is cold spot is the characteristic of multiple myeloma. So when you have a lytic lesion but the bone scan does not show increased uptake, that is what we call as a cold spot, and that is a feature of multiple myeloma. This was a recent question where they asked what is a super scan. So a super scan is an investigation where all of the bones are taking up so much uptake. Look at this, that even the kidneys are not seen. So this is a super scan where all of the bones are showing diffusely raised uptake, and this is what we see in metabolic bone diseases, because now all of the bones of the bodies are affected. The other theoretical possibility is where you have many metastases. All of the bones have multifocal metastases resulting in super scan. So that is what you need to know about bone scan. HIDA, I already said, is for the biliary system. So one, we had addressed that how it is having high accuracy in acute cholecystitis where you will not see the gallbladder. Second application is in bile leaks, where they are very sensitive, but it does not tell you the site. It can't localize the site or the type of the bile leak. And the third application is extrahepatic biliary atresia. In biliary atresia, HIDA scan can be used as a rule-out modality. If HIDA is normal, it means it can't be EHBA. But if HIDA is abnormal, then I'm not very sure. It can either be biliary atresia or it can be hepatitis. And that's why the gold standard for extrahepatic biliary atresia is an intra-op cholangiography. You have to puncture the CBD and see whether they are patent or not. Sestamibi, multiple times asked, almost every year in one of the exams, these questions will come. This is parathyroid adenoma. Investigation of choice is a Sestamibi scan. Sulfur colloid scan is used to pick up the reticuloendothelial system. In the liver, if you see a hot spot, there is one tumor which has the presence of Kupffer cells, which are macrophages. So if you see a hot spot on a sulfur colloid scan, that diagnosis becomes FNH. FNH stands for focal nodular hyperplasia. So FNH is a lesion with a central scar, and you will see a hot spot with the sulfur colloid scan. Technetium pertechnate is the investigation of choice for Meckel's diverticulum. Okay, so Meckel's diverticulum, painless GI bleed. Remember, technetium pertechnate. In addition, in Warthin's tumor, salivary gland tumor seen in smokers, you have pertechnate showing us a hot spot. Fine, so that's pertechnate. We have two renal scans. DMSA, the name tells you everything. It's a static scan. It's like taking a picture of the kidney. It's a static scan, or M for morphology scan. So it tells us about the activity of the compound in the kidney, and if there is any non-functional area, that is going to be called as a scar. So this is the investigation of choice to pick up renal scarring, that is DMSA. DTPA and MAG3 tell us about the function. So these are functional scans or dynamic scans, which tell us about the functional excretion and whether or not there is any obstruction happening in the kidney or not. So they are the investigation of choice for functional or dynamic ability of the kidney. So now we talk about PET scan. Again, lots of questions come from PET scan. So what you can see here is a combination of not just PET but also a CT alongside, which is done most commonly. So this is what we call as a PET CT. It's a hybrid investigation of nuclear medicine as well as radiology. What does PET stand for? So PET stands for positron emission tomography. Positron emission tomography. So this is where I use a compound that is 18-fluorodeoxyglucose. 18-fluoride. 18-fluoride is what is used as a positron emitter. Deoxyglucose is the carrier. So you know how the cancer cells in the body are all relying on glucose preferentially, right? So these are the cancer cells here which are preferentially utilizing glucose by glycolysis, which is anaerobic glycolysis. That is a bit controversial whether it's anaerobic or aerobic. Decide whatever you want to. So this is Warburg effect, right? So the cancer cells, when I inject glucose in the body, they are preferentially going to take up that glucose, and along with the glucose goes our positron emitter. So somehow my fluoride has landed up in the cancer cell. Yeah. Now what happens is this fluoride will emit the positron. We have a lot of electrons, so the positron combines with the electron, and when this reaction happens, that is called as annihilation, and that results in the production of these two gamma rays of 511 kilo electron volt. And then when I put my patient inside the scanner, it is going to detect these two gamma rays, and that's how we localize that, okay, these are perpendicularly released, so this must be the site. And that's how we realize that, okay, this hotspot is the tumor or metastatic focus. So that is why PET scan is the investigation of choice to pick up any metastasis. Very, very important. Few points here. Glucose, because the whole point is glucose, we have to make sure that the patient has normal sugar, right? This will give you deranged results in patients whose sugar values are not in the normal range. So if you have a diabetic patient, you need the patient to be well controlled before you can do a PET scan. That's the first point. Second point, any place which is inflamed can also show preferential taking up of the glucose. So a frequent false positive is tuberculosis, especially in a country like ours. There are many cases of TB. Active tuberculosis can also show you a false positive PET workup, and you can see a false negative, meaning you have a tumor but still the PET is negative. That is a typical carcinoid. So typical carcinoids tend to give you a false negative with PET. So that's a repeat question again. So 18-FDG PET, we said, is the investigation of choice for metastasis. There are few special PETs you should be knowing about. So sodium fluoride PET is particularly useful for bone metastasis. It's the investigation of choice for bone metastasis. This is an FMG question, last year question. Choline or PMSA PET is something that is very, very useful in prostate CA. PMSA stands for prostate membrane specific antigen. DOPA PET is what you see for pheochromocytoma. DOTA PET is used in neuroendocrine tumors. Very, very important potential question. And C11 Pittsburgh compound is a recent advance that is being done for Alzheimer's dementia. So few recent advances, potential questions from PET scan. Moving on to radiotherapy now. So here what you need to remember first of all is the difference between a teletherapy and a brachytherapy. Teletherapy means we are giving the radiation from a distance, right? Telemedicine, teleradiology from a distance. So from a distance, I am giving radiation to the patient. Brachytherapy means you are going inside the tumor and giving radiation. For example, if there is a prostate CA, you put these radioisotopes inside the prostate. So that's what is brachytherapy. Brachytherapy has the advantage that the surrounding organ damage is reduced, right? So the surrounding organ damage is reduced because you are going inside the tissue. But in teletherapy, everything in the line of the tumor will be irradiated. So that's why brachytherapy is better when you have a tumor, right? The only exception being a very large tumor. If it's a very large tumor, brachytherapy may not be effective. The disadvantage is when I'm putting the radioisotope now, the operator may get exposed to the radiation. So how can we avoid that? So that is a repeat question. This technique that is being shown to you here is what is called as remote after loading. So this remote after loading means that first the surgeon is going to put this grid and put empty pellets inside, and then using a robotic arm, we are going to place the radioisotopes. This technique of remote after loading is used for brachytherapy. That's a question you want to remember. Now, what is this machine that we are using to give teletherapy? So the machine that you can see here is a LINAC. A LINAC stands for a linear accelerator. This is what is being used most commonly now to administer radiation. Linear accelerator is used to make X-rays as well as electrons. X-rays are now the most common mode of radiotherapy. That is the most common agent of radiotherapy. Previously, we used to use nuclear reactors to give us gamma rays from cobalt, cesium. But X-rays are better because it's a machine. You can switch it on and off when you like. Cobalt can't be switched off, right? So that's what you need to remember, that linear accelerator is now being used most commonly. Cyclotron is something that is used to make protons. This is something which is very expensive, very new. We have only one cyclotron in India, which is in Apollo, Chennai. It's not even there in AIIMS. So cyclotron is used for protons. Now, why so expensive? It is expensive because of its special property. See, X-ray, gamma rays, everything else has this property that as the distance from the tumor increases, the effectivity keeps decreasing. But protons have a very unique effect. They have a big peak deep into the tumor. This peak is what is called as the Bragg's peak. Means they are very effective deep into the tissue, meaning that surrounding organ damage. For example, normally if I give gamma rays through my skin here, skin will have maximum radiation and then it travels down. But protons have no superficial damage. They're going to have their peak deep into the tissue, and that is called Bragg's peak. So both are questions: cyclotron producing protons, Bragg's peak property of protons. Okay. So this is about the mode of radiotherapy. Now let's understand this particular image here. So this is what is called as gamma knife. Gamma knife is a hybrid of neurosurgery and radiotherapy. So this is what is called as stereotactic radiosurgery. This is just like doing a surgical strike. Do you understand surgical strike against a terrorist? What we need to do is know the exact coordinates of the terrorist and attack there without any collateral damage. That's what we want for a tumor. For a intricate area like brain, I want to attack the brain tumor without collateral damage to the surrounding organs. What do we need for that? We need coordinates of the terrorist. We need coordinates of the tumor. So this is a helmet or a frame that gives us the coordinates of the tumor or the terrorist. So this frame is called as Lexell frame or the gamma knife helmet because this was discovered by a scientist called Lars Lexell. So this gives us the exact coordinates of the tumor, and that's where you give a focused radiation using gamma rays. The compound that we use is cobalt-60, which gives gamma rays. The body counterpart of this, so this is used for brain tumors. So this is used for vestibular schwannomas. This is used for pituitary adenomas, right? So these are a few applications here. The body counterpart of this, which is being tried out in CA lung now, is what is called as CyberKnife. CyberKnife has no frame, right? That is what has no frame, and we use LINAC there. We use X-rays there instead of gamma rays. So that is what you need to know about gamma knife and CyberKnife. The last table here about radiosensitivity, at least one question gets asked. So the most radiosensitive cell type are cells which are undifferentiated or cells which are rapidly dividing. The least sensitive cells are the quiescent cells, the cells which are not undergoing division. The organ that is most sensitive is the gonads. So basically ovary or testis, whatever they give. Least sensitive organ is the vaginal epithelium because it is very well differentiated. The blood cell which is most sensitive has the largest nucleus, and that is a lymphocyte. Whereas least sensitive is platelet, very small, no nucleus, so least sensitive. Cell cycle which is most sensitive is G2M. Repeat question. S is least sensitive. Sakht in Hindi means resistant. So S is most resistant. The tissue which is most sensitive is hematopoietic tissue or bone marrow. And least sensitive is the brain, right? So the neurons are least sensitive. With this concept only, you can also remember about acute radiation syndrome. Let's say there is a nuclear accident and sudden leakage of radiation. At what radiation will different systems be affected tells us the sensitivity. So the first syndrome is the hematopoietic syndrome, following which you have the GI syndrome, and then you have the cerebrovascular syndrome in the end. The hematopoietic syndrome will occur at a range of around 1 gray leakage of radiation. GI system will need around 10 grays, whereas cerebrovascular will need around 100 grays. So you keep adding 110, and this also explains the radio sensitivity. So this is about acute radiation syndrome. The structure of eye which is most sensitive is the lens, and that's why you have cataract. Least sensitive is sclera. Most sensitive tumor is Ewing sarcoma, and least sensitive is osteosarcoma. Last concept is inverse square law, very frequently tested. Intensity of radiation is inversely proportional to the square of the distance. For example, if this is the source of radiation, you were initially at position X and now go to position 2X. What will be the intensity? Double, half, 4 times, or 1/4? It will be 1/4, right? So it becomes 1/4. It reduces as you keep going away from the source by a square. Going on to the previous year questions, linear accelerator is X-ray and electrons. Radiotherapy, which of the following is true? Vomiting is not a late adverse effect. It's an early adverse effect. Signs and symptoms are reversible. No, they're irreversible. Dose of radiation is inversely proportional to the square is definitely correct. And it doesn't spare actively dividing cells. They are the most radiosensitive cells, right? So C is the correct answer. Patient diagnosed with cancer is undergoing radiotherapy. She is given 1.8 to 2 grays for 5 days a week for 6 to 8. This is what is called as conventional fractionation. When you give little radiation for 5 days and you give 2 days as break. If you give all of the radiation at once, this is frequently done for bone metastasis. When you give all radiation at once, this is called hypofractionation. And when you give 2 fractions in 1 day, and you don't give this break, this is what is called as accelerated or hyperfractionation. Radiotherapy done for aggressive tumors like small cell CA lung. So this is about the radiotherapy questions from nuclear medicine. Most sensitive, parathyroid, this is the one question that keeps coming every time. So when you have both in the options, we go for SPECT. If you don't have this, just go for technetium sestamibine. That is it from my end. I hope you enjoyed this radiology revision 2.0. And this is probably the only thing you require for radiology. At least do this one more time when you're sorted for the exams. Thank you so much. My final message, just stop wishing, start doing. This used to be a wallpaper when I was preparing for NEET PG. A lot of time we think a lot, we make a lot of plans, but we don't do much about them. So trust the resource that you are doing, trust yourself, believe in yourself. It's all going to be great. Thank you so much. See you soon.